So welcome, and I'm so happy and excited to have all of you here for this webinar. First, I wanted to make sure that you put a face to who is talking today, but then I'll turn off my camera so we can all focus on the slides. But I just wanted to say hi to everyone, and thank you so much for being here today. All right, so hopefully everyone can hear me well. So I will go ahead and get started on our presentation. And today we will be talking about fetal alcohol spectrum disorders. So let me try to see. Yes. And as you have seen before, some of our objectives for today is to be able to understand kind of like the impact of alcohol on the unborn baby, and then talk a little bit about what kind of impact it has on the brain of an unborn baby. Then we will go through and try to understand some of the symptoms and red flags of fetal alcohol spectrum disorders. And finally, we will be able to gain some knowledge on the general impact of prenatal alcohol exposure across the lifespan, going from early childhood to adolescence and then to adulthood. And then what is the impact of raising a child, having a child, treating a child, and an adolescent with fetal alcohol spectrum disorders within different systems, and what we all can do about that. All right. So if we were live, live or face to face today, I would kind of like have gotten started to ask about how many of you had a chance and a privilege to work with anyone who had been impacted with fetal alcohol spectrum disorders. And then kind of like try to gauge. But now that you are in this webinar trying to gain some information, I would think that you all have some interest in this topic. Some of you might have maybe more exposure, had more clinical experience. Some of you have some lived experiences. So I'm hoping that this information will kind of cater to all of you in some way. And then every 15 or 20 minutes or so, we will take questions. So I will kind of like pause a little bit and try to address your questions. So please feel free to put those in the question section. I'd be happy to answer your questions as well. So first of all, I wanted to start out with talking about, for those of you who might not have as much experience in this area, as to what is fetal alcohol spectrum disorder. First of all, fetal alcohol spectrum disorder is an umbrella term. It's an umbrella term, and it is a spectrum of that kind of like tells us different types of disorders that are underneath that. But it is a disorder that results directly from prenatal alcohol exposure. And fetal alcohol spectrum disorder is the most common leading cause of preventable cognitive impairment and developmental disabilities in the United States. And when I say preventable cognitive impairment, what I mean is that, for example, we know that Down syndrome is due to it's a chromosomal abnormality. We have some other genetic disorders, things like Prader-Willi syndrome, we have Fragile X syndrome. So we can determine genetically what would be some of the causes of those cognitive impairments or intellectual disabilities. And those are not preventable. However, fetal alcohol spectrum disorder is preventable because how it happens for a child is direct exposure prenatally to alcohol. And it is as a result of the mother consuming alcohol during pregnancy. We will talk about the impact in the next upcoming slides. So first of all, what we should understand is that alcohol is a teratogen, which means that it can pass through the placenta. So let's think about an adult and an adult consuming alcohol. So when we consume alcohol as adults, what happens is that, of course, it has an impact on the brain. And think about the time maybe when each of us had if so, had some experience with being intoxicated, or seen someone or worked someone who had been intoxicated. So what happens is that when there is alcohol exposure, of course, the brain gets impacted, but on a temporary basis. yes, the individual then starts to have difficulties with walking. So there are balance issues. There are difficulties with talking. There is slurring involved. There are difficulties with attention and memory. We have a hard time remembering things that might have happened when a person was intoxicated, right? So there are memory difficulties, attentional difficulties, difficulties with good judgment. So that impacts directly our ability to engage in goal-directed behaviors and in engaging in good judgment, right? So all of these things are the direct impact of alcohol, and that is more on a temporary basis. However, when we think about the unborn baby, alcohol being a teratogen, it is a dangerous substance to the brain. And adult brain is able to process alcohol and then get rid of it, let's say the next day, and therefore the impact will not be seen or visible within the next day or so after you've had enough liquids and then rested and so forth. But that's not the case for an unborn baby's brain, because the brain is not yet developed. So what happens is that when alcohol in the unborn baby's brain enters the brain, it passes through the blood-brain barrier. And what happens is that it stays there and it starts to accumulate. And the unborn baby's brain is not able to process it the same way as the adult brain does. Therefore, as it stays there, it starts to harm what we call the neurons, which are the brain cells. And it impacts different parts of the brain. And we will talk about what those different areas are. And therefore, it leads to the damage of a structural damage and therefore a functional damage later on in the brain. So that's why we say alcohol is a teratogen, and it has a much more adverse impact on the unborn baby as opposed to adults. So the next thing that I wanted to talk about is prevalence. And when we say prevalence, how often do we see fetal alcohol spectrum disorder? Well, first of all, the current prevalence rates indicate that FASD is a significant public health concern. And how do we know that? First of all, again, I know I cannot interact with you directly, but I wanted to ask and pose this question to all of you. Do you know what is the prevalence rate for autism spectrum disorders? So I'll have you think for a second. And maybe some of you, are working with that population, have that information, but the latest prevalence rates are 1 in 54, which makes it around 1.8%. So almost close to 2%. And what do we know about autism? We know a ton. It's everywhere. We have organizations, we have great screening measures. The pediatricians use a lot of the autism screening measures to screen for autism. There are great treatments. There are a lot of opportunities, for families and those impacted by autism spectrum disorders. And the public also have a lot of information and knowledge. To anyone you ask, I'm sure they have a lot of, information about what it may or may not be. And especially for individuals like yourselves who are in this, mental health field, we have a lot of information about autism spectrum disorders. But yet, the prevalence is not even close to 2% yet. However, when we compare that with fetal alcohol spectrum disorders, going back to my first question, how many of you were even aware that there is a disorder called fetal alcohol spectrum disorders? Now, why am I saying that? Because the prevalence rate. Okay, so kind of like going back to this slide with the prevalence rate, some of the studies going back to 2014 indicated that in the Midwestern US communities, the full range of fetal alcohol syndrome ranged from 6 to 9 per 1,000 children. And then the total rate of the fetal alcohol spectrum disorder, which is the whole range, was about 2.4 to 4.8%. And then it was also replicated by POPOA in across the world. And so it's not just something in US that we are seeing this, but it is also around the world, and we have similar results. And then the latest, as you can see at the top of this slide, the recent research is from May et al. In 2018, and they looked at the first graders in 4 US communities, and then the ranges are also somewhere from 2 to 5%. And similar results have also been found in West European countries, and that's also around 2 to 5% of children meeting the criteria for FASD. So what does this mean? This means that this is quite prevalent. It is there. However, we do not possess and have the same amount of knowledge, awareness, and efforts to help those individuals impacted by FASD or to engage in prevention efforts, such as all of you are here to learn about it, which is wonderful. And then we all are working in different domains and different revenues to increase awareness about fetal alcohol spectrum disorders. But I wanted to really make that clear that it is really prevalent. However, it is not known as much as other neurodevelopmental disorders. So how does fetal alcohol spectrum disorders develop? What is the etiology? Well, I mentioned the etiology, which is pretty simple there. Alcohol is the necessary factor for a diagnosis. If there is no prenatal alcohol exposure, then there is no FASD. However, now let's talk about some of the nuances. Then you might say, well, maybe I have heard about a mother. I worked with a adult and a mother who said that they have drunk alcohol during pregnancy, yet they do not have a child who has FASD. And then another woman said that they drank only 1 or 2 glasses, and then they ended up having a child somewhere on the spectrum for FASD. So then what gives? First of all, not all children who are exposed to heavy alcoholic consumption during pregnancy are affected the same way and to the same degree. Then you might ask the question, then how and why? Well, I wanted to talk a little bit about that piece. First of all, pattern and quantity of alcohol consumption is very impactful. And what does that mean? First of all, some mothers will engage in heavy daily alcohol consumption due to their substance use issues, due to their background in sexual abuse, trauma, other mental health disorders, their life circumstances. And if they consume alcohol heavily throughout the whole pregnancy, then they will likely have a child who has what we call fetal alcohol syndrome, meaning that the child has been prenatally exposed not only in the first trimester, but the second and third, and there has been heavy consumption of alcohol. Therefore, that child will be on the more severe end of that spectrum in terms of the cognitive, developmental, and other implications. On the other hand, we might have some women who during their pregnancy had rough patches, rough moments, and they consumed alcohol in the first trimester versus third. Okay, and some we will engage in what we call binge drinking. So what was shown was that the 2 of the patterns, which is heavy consumption throughout the whole pregnancy and all 3 trimesters, as well as binge drinking, was shown to be the most harmful and dangerous forms, as opposed to, I would say, the others. However, it is very hard to determine when the different parts of the brain and when different parts of the body organs will develop. As much as we have good information about when things develop, it's really hard to say for each individual exactly when, which day. So if the mother drank during that day when the development happened, then it will have an impact. But maybe it happened 2 days ago, and then the development of that specific organ or brain structure happened a little later, then we could see less effects. But I'm going to ask you this question: how can we know? How can we know exactly? We cannot. We do not have a method to track and follow that. Therefore, it's very hard to know if there is a safe, time or amount of alcohol consumption during pregnancy. Therefore, the current recent, research indicates that there is no safe time, nor there is no safe amount of alcohol during pregnancy. And that is a very clear message that I think that we should all share with all the, childbearing women that we are working with the youth that we're working. I'll talk about some of the educational systems later on, with the individuals who have already been impacted for their future pregnancies. So that should be a really, really clear message that I think as all healthcare or mental health professionals, or those who are having a lived experience, to share that information with those who might be impacted in the future. So a little bit more on the pattern and then the timing of consumption. For those children whose mothers drank during the first trimester, that's when the basic body parts kind of like start to develop, and then the brain with the spinal cord starts to close and then kind of like start to form really nicely. And that is the time, if the mother drank during this first trimester, then later on what we see is abnormal facial abnormalities that is very specific to fetal alcohol spectrum disorder. And I'll show you some examples through pictures in your slides. And you also have those as they are downloaded here as well. On the other hand, if a mother drank during more heavily on the third trimester, the third trimester is for those of you who have also had babies would know and appreciate that that's when the brain development happens the most. So that's the time when the brain organs are there, and then there is very fast proliferation of the neurons. So all the structures are doing their best to kind of like grow, so that they're getting ready to survive, out of the womb and then to support the baby. Okay, so therefore, if we have heavy consumption at the third trimester, then what we see is a lot of cognitive issues, a lot of neurodevelopmental difficulties, executive functioning difficulties, and all of those I will talk about today. Okay. So all in all, what we can say is that what we know as the fetal alcohol syndrome, is only seen in patients whose mothers drank heavily and chronically throughout the all, 3 trimesters. Okay. And another important piece is that we really cannot do much research with pregnant women. Therefore, we cannot have them in 2 groups and say this group does this group does this. Of course, not ethical. So all we know for research is we have animal studies, as well as we have retrospective studies where we can ask about the women in terms of their alcohol use. And as you would all guess, if I ask you what you drank, not even alcohol, but what did you drink for last night's dinner? I'm not sure if all of us would be able to remember exact amount or what we drank like a couple days ago or a week ago. So that's very hard to determine that piece, right? Therefore, as a result, the clear message is no safe amount of alcohol during pregnancy. So as you can see here, there is necessarily no new information here, but remember we said it is an umbrella term. So all you see here at the top is the fetal alcohol spectrum disorders, and underneath each we have the full-blown fetal alcohol syndrome, where we have the heavy consumption. Okay, then we have alcohol-related birth defects. That's when more we have some of the organs in the body are impacted, like a lot of the heart issues, eye issues, skeletal issues. Then we have alcohol-related neurodevelopmental disorders. This is when we do not necessarily have the growth issues or the facial features, but we have definitely the impact of the third trimester. Remember the ones I talked about, like there is a lot of brain development, and then it impacts the development of the brain. So that's when we will see a lot of the developmental issues. And then we have the partial FAS, where we will have not we have the growth retardation, the growth issues, and the neurocognitive issues, but not necessarily the facial features. So overall, a lot of the children really fall on the alcohol-related neurodevelopmental disorders, and a lot of them won't have the facial features. So therefore, sometimes FASD is referred to as an invisible disability. So as you can see on this iceberg, right, you see at the top, you only see very, seldom of that population who has the facial features, and then we can say, yes, this child has FAS. But then if a child does not have facial features, then if we are not looking right, if we are not educating ourselves about what FASD looks like in an individual, then we are missing all that bottom part of this iceberg, right? So we are only seeing what we can see visibly, but we are not really seeing what we can't see. And that's why you are all here, to start this journey, start this process of learning more about FASD. So actually, for today's presentation, I will be focusing more on the symptoms and red flags, but I wanted to all give you a little primer that in my next training and presentation in April, so I hope that some of you can also join that, which would be a nice segment into where I'll be talking about the diagnosis and all of these specific diagnoses under the spectrum. So I'll go into more specific detail in that presentation. So today I wanted to kind of like keep it more towards what are the symptoms and what are our red flags. So I will focus more specifically on that. So remember, I mentioned about alcohol being a teratogen, right? So alcohol impacts the brain, and what it does is it shrinks the general volume of the brain. And as you can see in this picture, to my right, the one that is smaller, is two infant brains that have passed, and one with and the other without prenatal alcohol exposure, and the other one was from SIDS. As you can see, the one on the right, it does not have as much of the folds, right? As you can see on the left has a lot of nice folds. So those folds and wrinkles on that left picture, okay, that's how a healthy brain is supposed to look like, okay? And then we see also a larger volume on the one within the healthy infant without the alcohol exposure. So it's much bigger. It means that there is actually more space for some of those brain functions to develop, because there is actually more structures that are allocated to each of these structures. But on the right-hand side, as you can see, the volume has decreased, and that is a direct impact of alcohol in the brain that is decreasing the volume. And that's why individuals who have fetal alcohol syndrome or any of those disorders under the FASD umbrella, they usually will also have what we call microcephaly. Microcephaly is when the brain head circumference is lower, meaning that the brain volume is lower and smaller. And what that means is some of the brain functioning and functions will be limited or decreased as a result of this decrease in the brain volume. So this is usually striking to see, because we do not necessarily think about the impact of alcohol on the adult brain this way. Well, if for those individuals who drink over the years, who have substance use issues, and they do not stop and they do not get treatment, then what happens is the same for adults. Over and over in time, alcohol starts to shrink the size of the brain, and then individuals who have FASD and individuals who end up having conditions like Korsakoff syndrome as a result of years of continued alcohol use, they end up having the same type of brain. But one is acquired over the years as a result of substance issues, and then FASD is these kids, these children are born with that as an impact of the prenatal alcohol exposure. So I wanted to talk a little bit about the impact of alcohol exposure in the brain. Yes, there are a lot of terms, and a lot of these terms, for those of you who are not necessarily in that little bit of that medical field, may not be as familiar, but some of those I'm sure you've also heard along the way, like the frontal lobe and things like the hippocampus. So, and then the reason why I decided to include this one is not that we will all be responsible for knowing specifically where and how alcohol impacts, but I really wanted to give you a visual as to, wow, alcohol makes an impact on the whole brain. It's not just one area. Okay, and that was my kind of like general goal for all of us to see and appreciate and understand that when we are learning about FASD, when you are advocating for your clients, when you are engaged in prevention work, dissemination of this information, that it makes you even more passionate, about this topic and the population to be able to understand the general impact on the brain. First of all, our frontal lobe. As you can see also on the slide, the frontal lobe is the most evolved part of our brain. It is on the front side where our forehead and then the sides are, and that's the area evolutionary that evolves the last. Frontal lobe continues to develop till our mid-20s. And this is the area where individuals engage in judgment. It's the area responsible for planning, organization, engaging in goal-directed behaviors, initiation, self-monitoring. So all of those skills that we call executive functioning skills. This is a really important area. This lobe and the functions of this lobe is what really sets us apart from other species. We are human based on our really frontal lobe because we have the capacity to engage in good judgment. We have the capacity for decision making. We can plan and organize like no other species can. So, what is the impact of alcohol in the frontal lobes? Alcohol has a direct hit and impact on the frontal lobes in the area of what I just explained, the executive functioning skills. So therefore, an individual impacted by a prenatal alcohol exposure will have less develop in these frontal lobe areas and will therefore have significant issues with executive functioning skills, which I will also explain in the upcoming slides. For corpus callosum is a structure in the middle of the brain, which allows the two hemispheres, the right hemisphere and the left hemisphere, to communicate nicely with one another. So if you see something on your right visual field, that information will go to left hemisphere, and then the left hemisphere will be able to say, yes, I saw this slide that Dr. Argun is showing. So it's all as a result of our corpus callosum. So what happens is that alcohol also impacts corpus callosum development, and some individuals with FASD are even born with either what we call a genesis of corpus callosum, meaning that part does not develop at all, or some part of it develops and then some part of it is less developed. Okay, or sometimes we see thinning of the corpus callosum. So what it means is that the two brains are not interacting with each other. One brain is doing something, the other one is not as much aware. So then what does that mean? For those of you who have worked with or have loved ones with FASD, sometimes, I don't know if you find yourselves in wondering, like, I am giving this information, I am not sure it's kind of like going through. Well, that's true because of the impact on the corpus callosum. It is getting into the brain, but it's kind of like getting stuck there, or it's moving on to the other side very slowly. Okay, so that causes issues with information processing, like getting that information, understanding it, and integrating. The next area that gets a direct hit a lot is hippocampus. Hippocampus is the area where we form our long-term memory, and alcohol has a huge impact for decreasing the volumes on the hippocampus. So what that means is that an individual with FASD will have a lot of difficulties with memory, remembering things, forming new memories, and putting them in their long-term memory. They can remember on the short term, but when it comes to transforming them to long-term memory, then they will have a lot of difficulties with that. Again, we can all appreciate that. Now, as I talk about each brain section and structure, I'm all inviting you to think about a time maybe when you or someone you know has been intoxicated. And think about all of these areas. Frontal lobe, well, can someone who is intoxicated engage in good judgment? Not really. Can they process information efficiently? Not really. If you ask someone who is intoxicated, how will their memory look like? Not great. They will not remember what might have happened the night before, right? So I'm inviting you to think, what is the impact on the adult brain that is fully developed? And this is a temporary impact. Now, what we're talking about here is not temporary. It's there, and it's prenatal, and it's not going anywhere. The next area that's impacted is hypothalamus. Hypothalamus is a brain structure that kind of like helps us with our self-regulation. And self-regulation meaning our ability to be aroused, to be conscious, to engage in our day-to-day functioning, knowing when we, wake up in the morning, knowing that what we do, and just engaging in our daily rhythm. So individuals with FASD, because of the impact on hypothalamus, they would have a lot of difficulties with self-regulation, soothing themselves, calming themselves down. They do not have those skills innately. So they have to be taught, they have to be assisted and helped with some of those skills. The next area is cerebellum. Cerebellum is at the back part of our brain. It's kind of like the part that connects our spinal cord to our brain. It's the area for balance. It's the area for motor coordination. So again, think about someone who is intoxicated. What is the first thing that the police asks them to do if they get caught? Well, the whole famous, walking, test, right? Someone who is intoxicated will have balance issues because alcohol directly impacts cerebellum. So therefore, what we see in individuals with FASD is a lot of issues with motor incoordination, difficulties with balance, a lot of accidents of falling and being more prone to falls and accidents in general. Another area is amygdala. Amygdala is our hub for emotional regulation. That's where we form our emotions. That's how we understand others' feelings, facial expressions, and social processing of everything around us. Again, amygdala is impacted, which leads to a lot of difficulties with emotional regulation. Therefore, we see a lot of emotional dysregulation. Therefore, it becomes one of the target areas when we work with our clients with FASD. And then the last part that's impacted is basal ganglia. This is the area that's also related to motor coordination, which leads to problems with fine motor skills, gross motor skills, some delays in the emergence of these skills, and difficulties with engaging in sports, difficulties with handwriting, difficulties with anything that requires, visual, and then motor skills, anything to do with their hands or feet and extremities. Okay. So I know that that's a lot of information. You might have some areas to follow up. So I just wanted to stop and ask our organizers to see if there are any questions that I can address so far before I move forward.
We don't have any questions related to the presentation at this time, Dr. Ergen.
All right, thank you, Karen. So I'll just go ahead and move on. So if you remember, we talked about facial features. And I mentioned that in the first trimester, if there is exposure to alcohol prenatally, then we see the emergence of specific facial features that are very special and specific to fetal alcohol syndrome. Okay, Alcohol impacts the midline of the brain. What that means is that the mid part of the body, the mid part of the face. Therefore, a lot of the features that we will see that's specific to FASD has a direct impact on the middle. So now, as you will see, all of these, different parts. So as you can see, we have, first of all, a smaller head circumference, and we talked about why that is. We talked about the brain volume being lower, and then the individual might have what we call microcephaly. And then we have, as you can see, those the area eyes, right? We have what we call epicanthal folds. So those are the smaller eye openings, okay? And that is also very specific to fetal alcohol syndrome. We will see a flat mid-face. Again, the mid-face, we will not see necessarily like cheekbones and all that, because again, alcohol impacts the midline, and therefore it prevents the formation of other parts like those cheekbones, and it kind of like flattens the middle part of the brain, the middle part of the face. And then we have that, smooth philtrum. So if you put your hands starting from the bottom of your nose, if you could put your fingers there, and then slide it down till where your lip ends. What do you feel there? Usually for a lot of people, there is some kind of like an upward bump, kind of like going up like that. That part is, of course, smooth, but it's just kind of like going up like that, up until to the end, to that part of the lips. So for individuals with FASD, this area is very smooth. Again, all of these parts are smoothed out as a result of the impact of alcohol. And then we see a thin upper lip. Again, that's in the middle. That area does not develop, and then it becomes like specifically very thin, and similar to the underdeveloped jaw area. So as you can see, everything kind of like coming down to that middle part where alcohol is impacting. So then you might see like, well, as opposed to Down syndrome, can we really see it with our eyes? Can we detect it? I'll show you within the next slide, so you can start seeing some of these similarities across race, across ethnicities, right? In the next slide. However, for some clients who had heavy exposure, okay, it is pretty much easy to see it that they actually have it. But for most clients, it will be very hard for us to see it with our own eyes and say like, yep, this person has FAS and they have the facial features, the facial abnormalities. So therefore, then you can ask, well, who can diagnose this? Who can determine this? This is specifically diagnosed by either developmental pediatricians, but specifically by the genetics department, by geneticists who are medical doctors who have had training in engaging in the facial measurements. They actually measure each of those, like what's the measurement from the eye opening from the nose to the eye? What is the circumference of the head? What is the length from the nose to the top part of the lip, to look at that philtrum. So they actually go ahead and they measure each of these facial features, and as a result of that, there are certain measurements that need to be there in terms of numbers, where they have to kind of like qualify that yes, there is a smooth philtrum, yes, there is an epicanthal fold, and there is microcephaly and so forth. Okay, so that is done by medical doctors at the genetics department, and it is hard even for more traditional pediatricians to engage in this kind of a measurement. So if you do have any suspicions, again, we can all have our suspicions. If we know that the child has been exposed to alcohol prenatally, and if you are working with them in some kind of domain, in some capacity, and you might notice some of these. Again, I cannot diagnose this. then it would be good to refer out to the genetics department, to a developmental pediatrician, so they can start that process of referral, because again, all of these also do take time, and so that they can actually be examined to see if they have fetal alcohol spectrum and the facial features or not.
Dr. Ergen, do you have time for a question?
Yes, I do.
We have one. It says, do you believe that FASD goes undiagnosed or possibly diagnosed as just an intellectual disability? I work in the DD field, and in the last 5 years, I have only worked with one individual with a diagnosis of FAS.
Thank you, Karen. This is a wonderful, wonderful question. Yes, I do believe, and it's not just my belief, there is great research that I will talk about more specifically in my next presentation in April when I start talking about diagnosis, but I'm happy to talk about a little bit now, is that the current recent research by Dr. Chasnov indicates that FASD is underdiagnosed. So yes, it is a missed diagnosis, and there is a lot of what we call misdiagnosis. What that means is, just like our audience mentioned, that a lot of the times, because there is so little knowledge and awareness about FASD, and our diagnostic procedure is not easy either, a lot of the times it's diagnosed, yes, as intellectual disability. It's diagnosed as ADHD, because I'll talk about that it leads to some hyperactivity and so forth. It is diagnosed as oppositional defiant disorder. Sometimes even it's mixed up with autism spectrum disorders. And later on, it could even lead to, due to the behavioral issues, it can be diagnosed as conduct disorder. And I've also seen it go towards more of the mood disorders like bipolar and so forth for the future when they become adolescents and so forth. So yes, it is usually missed, and then it is usually misdiagnosed as another neurodevelopmental disorder. So that's definitely a great, great, great point. Yes.
And then there's another question.
Sure.
Do you know of specific treatments through therapies that specifically affect the areas of FASD effects?
Yes, there are a lot of treatments. There are actually 4 and 5 evidence-based treatments, and I can, definitely talk about those, and I'm, happy to. However, I will have again in our training series, I will have a whole presentation about different evidence-based treatments, and I'll be introducing them in much more detail in that presentation. But a specific treatment modality is called Families Moving Forward. Just to drop a name and give a name for our audience, maybe who might want to, look that up. And then there are many other behavioral treatments that address all of the areas, all of the symptoms that I will be talking about today. And all of these treatments really focus on teaching self-regulation, teaching behavioral regulation, teaching about executive functioning skills. They do a lot of psychoeducation to the families to teach them about how to organize and how to accommodate and provide different accommodations both at home, at the child's school, in their environment, how to make those modifications so that our children are more successful and they lead meaningful lives without struggling as much. So I will have a specific presentation dedicated to treatments that I'm happy to get even more specific questions on those.
And then this is the last one.
Mm-hmm.
Do you think it is misdiagnosed or underdiagnosed due to parents not wanting to admit that they drink alcohol due to the stigma that comes with it?
Thank you, Karen. This is a wonderful question as well. Thank you to our audience who raised that question. So here are some barriers to diagnosis, and one is, yes, stigma. The parent, there is a lot of also focus and pressure on because we are saying that if there were no alcohol, then it wouldn't have been here. Yes, there is that, but then yes, it happens. So what do we do afterwards? A lot of our effort, of course, is prevention. But after that, a lot of our efforts are also on supporting that mother, and then making sure that they get this information, and then they will be able to get the diagnosis for their child, and also get the appropriate treatments. However, of course, due to the stigma, not wanting to talk about it, not wanting to share that, it is painful and it is difficult. So we as providers, we all feel, for those, parents who are raising their children, and they also have that, burden to carry. So that's one area due to the stigma. And then in one of our presentations too, on my last series, I'll be talking about stigma as one of the diversity variables that that plays a role in how we handle FASD. And there's a lot to be said on that, which is one is to reduce that stigma so that parents and mothers do feel comfortable sharing this information, so that it opens the door for their children to be diagnosed, and that opens the door for appropriate treatments, appropriate accommodations at school, and connecting with other families, connecting with other parents, and it just opens the way for many other things, if they were only diagnosed with, let's say, intellectual disability. And at the end, providers will also throw the towel. I've had to evaluate many teenagers who have not been diagnosed with FASD, but have been diagnosed with everything else under the DSM, diagnosis. I usually see, teenagers with 4 or 5 diagnoses having tried 5, 6 medications along the way, and nothing has worked. Everybody has said, we give up, we do not know what to do. And nobody has really looked into this prenatal exposure and the implications of that. So yes, there is stigma, and because of that, it gets underdiagnosed as well, but that's not the only barrier. There are many other barriers that get along the way, but stigma is definitely one of them. So that's a great question. Any others I can address?
That's all I have right now, Dr. Irvin.
Thank you. All right, so I wanted to show you all some other pictures. And as you can see, this is across different races and ethnicities. But if you can now all see those, look at the eyes and the apicanthal folds, like the small eye openings, and then the smooth philtrum, the thinner upper lip, the flatter mid face, and then the shape of the noses, as well as the jaw area, they all have, commonalities, and they're all, different, eye colors, different looking beautiful children that we see here. But they do have facial, commonalities, and they share as the features. So these children are the ones who do get the diagnosis of fetal alcohol syndrome, which is more the full-blown version under the FASD umbrella, where the mothers have drank during the first trimester and probably continued throughout the pregnancy. So just wanted to give you some more visuals as to what that would look like across different children from different various diverse backgrounds. All right, so that was kind of like my general introduction into, first of all, understanding what FASD is, how does that come around, what is it needed for FASD to emerge, and then how does it impact the unborn baby's brain, and then how prevalent is this? And now I can see that our audience also appreciates that this is something that is not known as much. It is misdiagnosed, it is underdiagnosed, there is stigma going around, and both from the providers, general public, and so it is not a easy way to kind of like handle and manage after it comes with the diagnosis and the treatments and so forth. So hopefully that was able to give you some beginning kind of understanding and awareness for those of you who have not been, exposed to this information before. And hopefully for those of you who have had the chance and privilege of working with someone with FASD, hopefully that part at least added some extra information in your repertoire. So the next part that I'd like to talk about for this next hour is the specific symptoms. Okay, and the specific symptoms, I divided them into different areas of the brain. So that's why I wanted to give you that visual of the brain and then how it gets impacted. Now I will be talking about, okay, well, we said that this part of the brain gets impacted, the amygdala, the frontal lobe, and so forth, which we are not as concerned about, again, but we are concerned about what that looks like in actually in day-to-day presentations. So I will be transitioning to that piece. And I give myself a little water break here. All right. So the first part that I wanted to talk about is the cognitive functioning, which is the IQ, the intellectual functioning. Okay. So research indicates that the IQ and the cognitive functioning of children on the spectrum is also on a spectrum, meaning that some of the children we see will have intellectual disability. So meaning that they will have IQs below 70 and below. Some will have IQs in the borderline range, such as anywhere from 75 to 90. And then some of them will have in the average range, 90 to 110. And then some individuals who have FASD will be in the gifted range. So what this means is that IQ is, or cognitive functioning is, impacted variably. And what that means is that not all individuals who have been exposed to alcohol prenatally will not have intellectual disability. So therefore, what we need to do is, of course, a psychologist needs to evaluate the cognitive functioning and therefore determine if there is also accompanying intellectual disability. So if an individual gets a diagnosis of FASD, then they could also be diagnosed with intellectual disability as a comorbid condition. Okay. However, when we look at the research across from all of the, the clients that have been impacted, what we see is probably not average, but not ID, but more in that borderline range. So somewhere around 80, IQ of 80, which is in the borderline range. It's pretty close to average, but it's not there yet when we average, in general. So what do we see? What is that gonna then look like? First of all, if we track and follow these individuals who have been impacted with FASD over time, sometimes we can see that the IQ scores kind of might tend to go down a little bit. Well, first of all, nothing to worry. It's not a deterioration. It's not a cognitive deteriorative process. It is just that their learning span and their learning process is slower. And therefore, when a child learns more slowly, it takes them time to turn them into long-term memory. And if you remember what we said about long-term memory for FASD, that does not happen very fast. Therefore, compared to typically developing children who make gains every single year, children on the FASD spectrum do make gains, but it's not as fast. So therefore, it kind of could look like their IQ points might go 1 or 2 points down, but which is not something that we should be specifically worried about. So it is not a cognitive deterioration. So they do continue to show improvements in their scores, but it's much of a slower improvement. So for those individuals who have an accompanying or comorbid intellectual disability, then what we need to do is that making sure that they have appropriate services, at school, because then they would be, they could get an individualized education plan, an IEP for the intellectual disability. They could get services at, different agencies. The parents can get respite care, they can apply to Social Security. So there are a lot of other opportunities that they can apply for with a comorbid intellectual disability. However, on the other hand, when an individual has average IQ, then sometimes it closes, some of those doors, because they might say, well, they do not have an intellectual disability. So then, just like one of our audience mentioned, that think about this child in school, average IQ around 100. However, they have significant difficulties with day-to-day living skills, okay, adaptive skills. They have a lot of difficulties with executive functioning skills. They have a lot of problems with planning and organization and regulating themselves. So that means they are struggling a lot. But just because they have average or normal IQ, then they get treated so. That's why I said at the beginning that FASD is an invisible disability. If there is a accompanying intellectual disability, then it gets noticed more. And just like our audience said, that's the first thing that gets diagnosed, because it is so much easier to diagnose ID than FASD. So I want all of you to keep that in mind and not discount or kind of rule out FASD just because for a child who has developmental delays, let's say if they do not end up having ID, but there is some kind of like exposure in their background, we should keep looking and keep referring for FASD and not give up on that piece, because I have seen, and some of even our community members, we talked about that a lot, and I'm sure some of you have experienced that too, that for those who are more on that surface, who don't have the facial features, who don't have ID, to everyone else they would look very typical from outside, but we know that they struggle with so many other things. Okay, so that's why I think emphasizing this, I find it really important. All right, the next area that I'd like to talk about, that individuals with FASD show a lot of symptoms and difficulties, is the area of learning and memory. So when we think about memory, I want to talk about different types of memories. First of all, the first type of memory that we have is short-term memory, which is when you hear any kind of information, whether it's visual, whether it's auditory, just like the things I'm talking about today. If we don't take notes, if we don't go over the slides, what happens to that information? It decays, right? We forget it, it goes away. That's why it's called short-term memory. So I'll just do kind of like a quick, exercise. Again, I want you to all, we cannot interact, but I want you to all kind of think for it for yourselves, okay? So I'm going to say a series of numbers. What I would like you to do is, once I say them, I would like you to say them in the same way that I say it, okay? So if we were in a one-on-one situation, then I would, once I'm done with those numbers, and I would expect you to say it. So I'll say it, and then you can all say it to yourselves afterwards, okay? All ready? 2, 4, 9, 6, 5. So some of you have said it all the same way. Some of you said like, oh, hang on, what was the last number? And maybe some of you got some of the numbers mixed, but if you were able to do that, that is a sign of good short-term memory, because the information stays there really short amount of time. And we have a very short window to remember it, unless we write it down, unless we code it, unless we practice it, and so forth, okay? Another type of memory is called working memory. Working memory is once we are given some information, but then we have to do something with that information in our head before we give a response, okay? And for that, I'm going to give another example. So I will give you, I will tell you some numbers and letters, and when I'm done, I would like you to say the numbers in order, starting from the lowest, going to the highest, and I would like you to say the letters in an alphabetical order. Okay, so for example, if I say 1A, 3, that wasn't a good example. Sorry, I have to start with 3. 3A, 9, then we're supposed to say 3, 9. So first order the numbers, then put A because first numbers come and then the letter, right? So I'm going to say it and then let's see if we can all do it ourselves and order first the numbers and then the letters in alphabetical order. Ready? 4D, 2H, 1G. So what we are supposed to do is first organize the numbers in our head. So that is, I said 4, 2, 1. So we have to put it all together and say 1, 2, 4. And then we need to go and look at the letters. I said D, H, and G in that order. So we have to do, D, G, H. So kind of order them as well. And then say all of that together. So this is called working memory. This is much harder, right? And now I'm going to say some numbers. After I say them, I want you to say them backwards to me. Are we all ready? 4, 7, 3, 2, 1. And then we say go. So we go then 1, 2, 3, 7, 4, right? So we have to remember the whole thing so that we can kind of like remember how it is backwards. So this is also called working memory. So why did I tell all about these pieces? So it will all kind of like make sense when I kind of like put all of that together. All right, and then our last example is what we call our ability to encode information. So that is our ability to learn information over a period of time. So when we are presented with information, we don't learn it right away, right? We have time, we need time to process it. We need time to digest it. We need time to remember it and put it somewhere in our brain where it belongs to. Now, after this presentation, you're going to put all this information in your, okay, this is a developmental disability, and this is all about alcohol exposure, so I'm going to put it right on my brain where all of this information goes, right? So this is our ability to encode the incoming information. So what I'll do is that I will read you a list of words, okay? And once I'm done, I would like you to maybe write down how many of these words in that list that you can remember. Okay, ready? Apple, bag, map, skirt, orange, rose, car, gum, glasses, ring. Go. I usually like to ask when I'm, face to face, like how many people, were able to remember and write down. And then now I will read it the next time. Don't look at the ones you've written, okay? So let's see now how many more maybe you'll remember. I'll read the same list again. Apple, bag, map, skirt, orange, rose, car, gum, glasses, ring. So I wanted to see if any of you who have written more words on the second round, because now that it's starting to encode in our memory, and normally these tests we read it 5 times, and by the 5th trial, typically developing individuals are able to remember out of these 10, 7, 8 of them very successfully. and they do not really engage in a lot of errors, like they don't put on words that were not on that list. Okay, so why did I tell you and give you these examples of some of the tests that we also do, which are neuropsychological tests? The reason I gave these examples is that because alcohol impacts hippocampus, and hippocampus is the area where we encode the information in the frontal lobe, and after that it turns into long-term memory. The short-term memory turns into long-term memory. So it specifically disrupts the areas. Therefore, individuals with FASD have a lot of difficulties with that initial encoding of the information. When we read this type of lists and when we ask them to remember, a lot of the times, initially, typically developing individuals will remember around, somewhere between 6 to 8. There are some who remember all, okay? Individuals with FASD, they remember so much less, like something like 3 to 5 and so forth at a time. And it takes them so many more trials for them to code this information, because it gets coded and it almost gets erased. It gets coded and it gets erased. It doesn't really stay there. It doesn't have that ability in that brain to stay there for longer periods of time and then to be transformed to long-term memory. Okay? So therefore, what does that mean? It means that we need to present information to individuals with FASD in smaller chunks. When it's smaller chunks, they are able to get it because they have good short-term memory. Remember the short-term one, we did just the digits? They are able to do that, but when they have to work it out in their memory, which was the numbers and letters task we did, that's the working memory, then they have trouble with that. They have trouble with putting them into long-term memory. Another difficulty that they engage in is what we call intrusion. Intrusion is, let's say in that list, did I say strawberry? And I would have loved to see hands for this one, but that list did not have strawberry in it, right? So that is what we call intrusion. So individuals with FASD, they do not remember, but they know that they have to remember something. So as a result of it, their brain kind of fills in the gap, which we call confabulation, which we call intrusion error, meaning that they come up with something, it's not lying, the brain comes up with something, but it's not the correct one. So each time they give the list, they keep adding strawberry in there because that's how they remember it, and then that's how they keep remembering it afterwards. Okay, so in daily life, sometimes we have issues with some of the children, kind of like parents, teachers, providers might think that kids may be engaging in lying, other than the typical lying that all children and teens engage in. They think that lying is pretty frequent, but that is more due to some of these memory difficulties that they fill in the gaps, and they're not really even aware that they are not telling the correct thing. Okay, that's what we call confabulation, and that's a really, really important piece that we really don't see this in other neurodevelopmental disorders. So we don't see it much in autism, we don't see it in ADHD, we don't see it in learning disabilities or Down syndrome and so forth. We see other types of memory issues, but not this type. So therefore, learning difficulties at the beginning, working memory, and confabulation problems are all prevalent and more specific to FASD. So if you are working with a child, with a teen and adult who is presenting at different ages, usually this you can detect more around school age. Before that, we don't really expect children to engage in a lot of memory tasks, right? If you see any of this type of an issue, that would be a red flag, and that will be a time that you could kind of start having those conversations with the parents to see if there is more to what you are seeing. What about language skills? First of all, some individuals will show some language delays and therefore will be diagnosed with expressive and receptive language disorder. So they would have articulation issues, they will have difficulties with comprehension. So a language disorder can be a comorbid diagnosis. if an individual has been severely impacted and has the full-blown fetal alcohol syndrome with the facial features and everything, then they could also show severe language delays. That's more common. So it's similar to the more severe forms of, autism spectrum disorder. The more severe, the more intellectual disability, the more language issues, the more behavioral issues that we see, right? So FASD is similar in that sense. Whenever we see the more full-blown version, then it means they have been more impacted with alcohol, and therefore more parts of the brain have been impacted. Therefore, we'll see more issues as an overall. But generally, what we could also see is that they might have basic language skills. So this is not a group that we will say, for example, as opposed to autism. In autism, we'll see more language issues, right? They'll have speech delays, they will have speech and language therapy in their history, they will have problems with communication. This is not something that we specifically see in FASD. So they can converse with you. That wouldn't be a difficulty. And then if you do not pay attention to some of that, the content and so forth, you could say that they have basic, conversation and language skills. It is not a problem. Okay. They can repeat back the information that they have learned, because remember we said they have good short-term memory, so that's not an issue. But what they struggle with is comprehension of complex material. So if you give them a passage and then say, what do you extract? What do you get from this passage? So let's say my 5th grader right now is reading a lot of things, and then they answer all these comprehension questions where they have to understand the text, but also they need to be able to take something away from it to answer a question. Or if you are talking with them, you want them to understand that, that hidden kind of like meaning. So those type of skills will be more difficult. And unless we have that kind of more deep conversation with them, then we won't be able to really understand that they struggle with it. Okay. So in that sense, what we can say is that, yes, sometimes language disorders could accompany, but a lot of the times basic language skills will be intact, and then we will more see problems in the more complex kind of comprehension difficulties. In terms of the visual motor, visual perceptual skills, sometimes we see difficulties with spatial orientation, which is kind of knowing about directions, reading maps, knowing where to go. And you can think about it as how that looks like when they're in the community, kind of like sometimes maybe getting lost, not knowing where they need to go. And that we could see that in some kind of forms of dyslexia, because reading is also very visual. And if they have difficulties with deciphering what they read, sometimes we could see a little more of those type of visual-based dyslexia. They also have a hard time understanding and detecting the nonverbal information. That's more like you perceive or not perceive. Sometimes they might miss the social cues. They might miss some of that nonverbal part of the communication, and therefore interpret the social situation in a different way. That could put them at a disadvantage for making social gaffes or putting themselves in situations where it might not be safe. So we'll talk a little bit more about it in the social skills section. Another area that we see a lot of difficulties with, and I think one of you also in the audience mentioned that when we talked about the misdiagnosis, ADHD is very commonly diagnosed instead of, or it is there too as a comorbid, but it's diagnosed as the only disorder when FASD is not detected. And the reason is that 70% of individuals who have FASD also have a comorbid ADHD. And you might say, why? Why is that so high? It's so high because of the frontal lobe. And ADHD is one disorder where frontal lobe is impacted genetically. And in FASD, because of the impact of alcohol on the frontal lobe, it kind of impacts the same motor regions in the frontal lobe that leads to this disinhibited behaviors and hyperactivity that we see and the inattention that we see in ADHD. So what are some of the things that we see and some of the things that we don't in the area of attentional issues? First of all, the ADHD in FASD is more secondary, of course. It happens as a result of the alcohol impact. It's not the genetic one that we know of, that's the primary one. So if a child with FASD also has ADHD, first of all, the onset is earlier, as early as 1.5 and 2. I was able to see in some of the clients that ADHD is there, and it is so severe and it is so disruptive to themselves in the sense that they cannot even sit and relax and rest for a second. Their sleep is very much disrupted. They move all the time. And for the traditional ADHD, when do we see those symptoms coming up more? Again, if we were interacting, I would have loved to ask, but it's usually around 4 or 5. It's not as early as this 2 and so, because right at that age, all hyperactivity is normal, right? It's within developmental range, but not for when it's with FASD. Even at 2, you can say this is above and beyond what I would see for any child who's about to develop ADHD genetically. So ADHD is more earlier, and it's more poorly responsive to standard medical intervention, meaning that I've seen a lot of children with FASD who were not diagnosed with FASD, but were diagnosed with ADHD at age 3. And usually we really don't diagnose ADHD by age 3, not before really 6, but they were diagnosed because it was actually there. And they have been put on medication, and the standard traditional medications don't really help. They will actually work much more, in a different way, and more therapies and behavioral regulation and self-regulation skills do work much better than the actual medication. So medication doesn't really work for the ADHD in FASD. So what is then the profile that we see usually? We see usually poor response inhibition, meaning that when you tell a child, when a child touches a hot stove, what happens? They pull their hand away from it because they get burned, they start crying, and then the next time, maybe they do it another couple times, but after that, most children are able to learn from that experience, learn from the feedback, and they inhibit themselves from not touching. So they don't touch it because it actually hurts. And they don't engage in this over and over again because they don't want to hurt themselves. Well, then children with FASD, they have hard time with inhibiting themselves. They engage in the same behavior. They have hard time learning from the feedback that they get, even from the parents or that internal feedback of being burnt. And then you might ask, why does my client do it over and over again? The area in the brain that helps us to learn and make that associative learning is highly impacted. Therefore, it doesn't mean that they will never learn. It means that the pathways in the brain in that area are more scarce. So we need to teach them, go over the same thing over and over again so that we actually make that pathway in the brain until the child is able to then make that association. Okay? So overall, they can sustain their attention generally. Remember, we said they have good short-term memory for a short period of time. Okay. However, what they really struggle is that focused attention and then not being impacted by distraction. Okay. Now that we are live, but you all are muted and you're all in your rooms, and let's say one of you has a child and keeps asking things to you, and that happens to me too when I'm sometimes lecturing and so forth, and I make some gestures and so forth, and then you just tell them like go away or just ask it later and so forth. So but then for individuals who have FASD and ADHD, when there is a distraction, they cannot not stay away from it. They kind of go towards it, they seek that part, and then they are very much impacted. So we are able to shut down distractions most of the time, but we can do that successfully. But individuals with FASD have a really, really hard time. So we have to be the ones as teachers, parents, providers to teach them some of those skills as to how to shut all of those distractors down so that they can actually focus at the task at hand. And when they focus, they have fine sustained attention. They can do it. They just need those environmental modifications and accommodations. So hopefully this is clear, and because it's an area that I get a lot of questions around as to how to differentiate, what to do. So I wanted to pause to a little bit to see if there are any questions so far for some of the areas that I've been talking about.
Well, this is a question. It says, hello, Dr. Ergan. What current diagnostic criteria or guideline do you subscribe?
Okay, even getting a lot of questions also on the diagnosis part. So again, as I said, hopefully you all can attend to the next one where I'll be talking about the 4 different diagnostic models. But first of all, as a clinical psychologist, I have to go with, because that's how we bill, with DSM-5 and ICD-10. So I do foremost have to go with that just based on my role as a clinical psychologist. And there we do diagnose as under, if I do think that a client has FASD, I diagnose with other neurodevelopmental disorders due to prenatal alcohol exposure. And then in my summary section in my report, then I talk about under which of those 4 diagnoses under FASD that I think that the client has. If I decide to diagnose with FAS because it's a full-blown syndrome and the client has already gone through genetic testing and they have facial features, then I indicate it in my summary, but I cannot put it as a diagnosis under DSM-5 because there is not a separate FAS diagnosis under DSM-5. So that's where that's what I go with, but I use that 4-digit diagnostic code of University of Washington. And I'll be detailing each of those and talking about those differences between those diagnostic systems in my next presentation, where it's all going to be about screening, diagnosis, and referral more specifically. But I hope that it addresses your question as to what I'm currently using and going off of with.
The next question is, does any of this stuff happen in adults with prolonged alcohol exposure?
Yes, as I mentioned at the beginning, great question. Whether they are diagnosed with a disorder called Korsakoff syndrome, where there is really prolonged years of alcohol use, that has the same impact on the brain. They have what we call retrograde amnesia, which is not being able to remember the past. Anterograde amnesia, which is not being able to make new memories. So the memory issues, learning issues, self-regulation issues, they become aggressive, they cannot regulate themselves, they cannot engage in day-to-day life. So we see the exact same things in individuals who have prolonged alcohol exposure as adults. Exactly.
The next question is, any ideals of strategies, ways to combat confabulation? This is the most frustrating characteristic to me.
Definitely. That's a great question. And yes, there are. And I'll make actually a note about that for when I talk about the treatments, to make sure that I include those as well in those trainings. And that will be the next one after the diagnosis section. So for confabulation, first of all, psychoeducation is really important, that the child or the teen or the adult needs to understand that this is what's going on. And then the people around them need to understand that, because otherwise you can get into that, are they lying or not? Why are they not telling the truth, and so forth. So if the child, and I always say child because I more work with the younger population, if they do understand that this is something that they do outside of their awareness, first making them aware that this is what they're doing. And then we can work on the fact that whenever you cannot remember something, you can tell me, I don't know. Because sometimes they feel compelled to give a response, and then confabulation happens. Okay, so we can kind of really work on that piece as to, you don't need to give me a response right now. If you don't remember it, it's okay. It's okay. And then they need to understand that it's okay that they do not sometimes remember things. Providing them with smaller chunks of information so that there are higher chances that information stays in their short-term memory. If you put too much information, they will more likely to engage in confabulation, because then the more information, the more they forget. And then the third one is, once we give them information, for example, we could ask them to self-talk, which is kind of whisper to themselves, say it back again. That more likely to stay in their memory if they kind of like get into that habit of like kind of whispering back to themselves. There are a lot of strategies for teaching executive functioning skills, and there is a strategy called attentional control training, and I'll be talking about that in my next presentation about treatment a little bit in more detail. But there are ways to definitely to address confabulation.
The next question is there more explanation as to why identical twins might show up somewhat differently on under the FASD umbrella? For example, both under the ARND section, but one had a heart defect at birth and has speech issues while the other does not have these things.
Yes, that's a great question, and I did also do like evaluations for twins, maybe not identical. I think I did fraternal, but of course, their identical twins' genetic makeup is much more similar, and we do expect that they would develop in the same way. However, even the distribution of alcohol in the womb, when in the utero, and then the position of the babies would even make a difference, because they're both there. So we could say like, well, they can't move to another place, but even where one baby is, and then where alcohol kind of like hits specifically, and we cannot control that, will make a different impact if that was a specific day where language development was happening, and then that, let's say that one twin was moving in the body, and then the alcohol kind of like passed by, and then the other one was sleeping, and then they kind of like the brain, it just got through the brain a lot more. We have really no way of controlling what the position of the babies are in the utero. Therefore, when alcohol enters the blood-brain barrier, there is really no way of knowing how differentially it will impact even the twins. So therefore, it is possible to see that we will not have the exact same diagnosis under the FASD umbrella, even for twins, although the chances are that they will both be more similarly impacted than fraternal and more similarly impacted than siblings who have been exposed at different time points.
The next question, I am wondering how often FASD is not able to be definitely diagnosed, but all or very many of the symptoms are there, and what can be done to help children in this situation?
Again, another wonderful question. So I do have statistics for you for that audience that asked. Up to 80% of the time, FASD is misdiagnosed. So that is extremely high. That's not like any other disorder. We do not have this high of a miss rate and a misdiagnosis rate in any other disorders that we are all working with. So I just want you to get your attention to there, and thanks for raising that question. And what can be done is screening, screening, screening. We are not screening this as much as we're screening autism or other neurodevelopmental disorders. Those of you who are working with the younger ones, working with the DD population, 0 to 3, early, mental health intervention specialists and so forth. I think the information on this has to go maybe more into the curriculums of how we are all being educated. In my program as a clinical psychologist, I did not get this training. It was not until my internship year that when I started to work in an FASD and international adoption clinic, that I got more exposed to this information. Now I teach it in my own program just because I'm there, but it should not really be this haphazard. We were talking about how it should be more integrated part of the curriculum in the medical schools, because even at the physicians level, there is a lot of lack of information about FASD, and they know more about FAS and the facial features, but they do not know enough about the alcohol-related neurodevelopmental disorders, which is the one that does not have the facial features. So I would say more education, better screening tools, more easier and more maybe client-friendly diagnostic systems, and more accessible treatment. Those are all the things that would definitely help with better, better identification of this disorder.
Next question. Can you confirm a diagnosis if birth history is unsure, such as with an adoption?
That's another wonderful question, and that's one I've do struggle with too. And so if the facial features are there, and if we do neuropsychological measurement, the neuropsychological testing, and we see evidence of 2 or more areas of the neurocognitive areas that I'm just talking about right now, and then if the birth history was not known, then we can kind of like go ahead and engage in that diagnosis. But again, I'm saying that with caution, in the sense that not all, and some of our caretakers and caregivers would appreciate that, is this is very differential in the world of medicine and psychology at this point. There are some who will give that diagnosis in the absence of that, and there are some who will not. And even though the client has all the facial features, the client has all the neurocognitive impairments, but the history is not known, then sometimes it's not given. So if the facial features are there and the neuropsychological impairments are documented, then because for me it's there, it speaks for itself, and I do give it. However, I also know some others who want to kind of like all that information, which is needed for diagnostically, but if it's not there, but everything else is there, it's not, I think, helpful to hold back the families from accessing the appropriate treatments. But as I will talk about different diagnostic criteria, I will list which diagnostic criteria needs to have the proof for prenatal exposure and which one doesn't when I talk about it in my next training.
And that will lead into the next question, Dr. Uran. Will the next training include the diagnostic information as well as treatment? Or
no. Yeah.
Will the treatment be its own webinar?
Yes, the next training in April is going to be on the screening, need for screening. And today's training, I will end with that. We need to screen based on all of these things. We need to start screening. Then I will talk about the diagnostic systems and the differences between them, and then the process of diagnosis and the difficulties and roadblocks. And then the referral process. Once we know that there is a positive screen, how do we go about engaging in that referral process as providers, or what do we do if we are the caregiver or caretaker? And then the training, the next one after that, will be specifically on treatments, and then advocacy. How do we advocate for our children or for individuals with FASD, and talking about resources. So they're all kind of like in a more serious. Today is more the general introduction, symptoms, and red flags that I will continue to talk about, just making sure I I can finish everything that I wanted to deliver for you all.
And I think this is the last question.
Mhm.
Does alcohol attribute to autism?
Does it lead to autism? No. Alcohol exposure does not lead to autism. However, if genetically the person is supposed to develop autism or has autism, and the mother also drank during pregnancy, and then the baby has been exposed to alcohol and they develop FASD, then we can diagnose autism and FASD at the same time. However, the autism would have developed uh, because it was genetically there, not because of alcohol exposure. They're separate in that sense. And that's why we said that FASD is the #1 preventable cause of intellectual disability, because if it's not there, alcohol is not there, there's going to be no FASD.
Another question came up. Are there incidence statistics for the number of children with both FASD and neonatal abstinence syndrome?
That's a good question. I would say not on the top of my head, but if the audience that asked it would not mind maybe sending me an email, and my email is at the last part of the slide. I do have it somewhere. It's not on the top of my head, but what I can say is that women who engage in substances, they rarely do it separately. So any woman that I have, the birth mothers that I work with or had a history about, who had used alcohols, they also used drugs. Or if they use drugs, they also use alcohol. So therefore, it's really important to screen for both. It's really important to ask for if they are drinking and using while they're pregnant. And then it's really important to also screen and look at the impact of the drugs on the baby after after they're born. So what happens is that the impact of the drugs is not as adverse as the impact of alcohol. Alcohol is the worst teratogen, then the drugs, then the smoking, cigarettes. So in that sense, they're usually all together in a lot of the cases, actually. However, as I said, I do not have the statistics of in terms of the diagnosis per se, but what I know is the incidence of both happening at the same time, just looking at their histories and so forth, is that they all happen all together. But I do have statistics somewhere, and I'm happy to share it with the audience if they would like to send me an email.
That's it.
All right, so I will move forward with the rest of the slides. So we talked about ADHD. The other piece is that in individuals with FASD, we can also see learning issues. And out of those, the biggest that kind of comes out is mathematics specific learning disability. Math skills are very difficult for individuals with FASD. They have hard time with knowing, understanding, learning abstract concepts. And math is all about that, right? Which one is more than the other? That's half than the other. Which operation comes first? So there is a lot of abstract information, and abstraction is all about in the frontal lobe. And we already learned that frontal lobe is really impacted. So they have specific problems, difficulties with money management and telling time. So those are the two things if you have a client struggling with those pieces, because typically developing children don't really struggle with those as much, or children on with different developmental disabilities, they could struggle generally with everything, but not just specifically with money, learning about money, coins, what their worth is, and specifically with telling time. So those are specific difficulties that we need to look onto. And math learning disabilities are pretty common in FASD and can be diagnosed comorbidly. In terms of executive functioning difficulties, I talked about these a little bit before, but overall, what I'd like to say is that this is one area that's also very specific to FASD. Because individuals with ADHD, for example, or autism, they do have executive functioning issues too, but not to this severe degree that individuals with FASD have. So what are those difficulties? Ability to plan, being cognitively flexible, switching from one activity to another. That's very difficult. Inhibiting themselves, forming concepts, understanding things that are abstract. Those are very, very, difficult things. Okay. So these all lead to, and then they also struggle with problem solving. When you give them a problem or just pose a problem like, oh, we need to do this today. Typically with, let's say, a 10-year-old, if you say that, they will try to come up with some answers for you. They can say, oh, we can do this, we can do that. That is a very difficult task. So what will be helpful with some of these executive functioning deficits or impairments is that we need to kind of like work those problems with them. We need to help them generate ideas. We need to help them to come up with lists. We need to make sure that the concepts are introduced in a more concrete manner, step-by-step manner. So those things and strategies will actually help them to make sure that they can actually function more successfully in a day-to-day life, because they really lead to marked, a severe adaptive deficits in day-to-day life. If they cannot plan and organize their day, if they have hard time with any kind of approach to any kind of a problem that they come across during a day, that becomes really hard to lead their own lives without assistance from others. And that's why some children and some individuals with FASD need a lot of supervision and a lot of monitoring and support in their day-to-day activities as a result of their executive functioning difficulties, which arise as a result of the impact of alcohol on our frontal lobe, which is the main hub or function where our executive functioning skills develop. What about the social skills? Our kids with FASD, they are social. They do approach others. They want to be friends. However, sometimes they have a hard time differentiating who is a friend and who is a stranger. For them, everyone can be a friend. Everyone can be nice. So they might have a hard time differentiating and going up to strangers and talking to them, giving them their personal information, which opens the door for being taken advantage of, being sometimes abused. So they have hard time sometimes with getting those social cues. So in that manner, sometimes it's similar to autism. However, one differentiation would be that in autism, they don't really want to approach most of the time. They're okay on their own. Whereas our children with FASD, they do want to be part of the social, network. They would like to make friends, but sometimes they don't always show the best prosocial behaviors. So they might get into trouble with peers, such as because they are very disinhibited, they might accidentally hit someone. They might get angry very easily. They might have some aggressive behaviors. Therefore, they could have trouble with forming peer relationship because of their behaviors and not getting some of the social cues. So all of these could lead to difficulties with making friends, maintaining those friendships, and then making sure that they remain safe in a social environment, which leads to what can we do for that is social skills training. And there is a really great friendship training with one of the evidence-based models that really focuses on the social skills of children with FASD, to teach them prosocial skills, to teach them explicitly what is right from wrong and how to engage in behaviors that will lead them to have successful peer relationships. So we talked about that the daily life is really hard, day-to-day life. So this is again one red flag that you can easily identify. Let's say you have a child who has normal IQ. What would you expect that their adaptive skills be like for a child with typical IQ? We would expect the adaptive and the daily living skills to be consistent with their IQ, right? So if you have the cognitive capacity, you can apply them in daily life, right? And hold and have a typical day-to-day life with no support or help needed. Well, kids with FASD or individuals with FASD, even though they might have typical IQ, which means that normal cognitive functioning, consistently their adaptive skills are delayed. So if you're working with a client, you go like, well, they had their IQ measured and tested, it's typical. Why are they struggling so much to just take care of themselves? Like, why do they struggle so much with dressing and all of these things? What is going on here? Then you should have a red flag. So we have that discrepancy between cognition and adaptive skills, and that's very much salient and very much discrepant in FASD. So what are those areas? Those areas are social skills, which we talked about, emotional maturation. They act so much younger than their age. So if they are 13, they'll maybe, could act like 8 or 9. If they are 8 or 9, they could act like they are, 4 or 5. So we are all in some form of clinicians, right? We're in this field of, mental health and health, and therefore we would have the means to do our behavioral observations, mental status exam. So by just when we are doing an intake and when we are interacting with these children, even though we don't think that they have an FASD diagnosis anywhere, if we realize that despite their intellect, they're acting really so much less mature than their age, this should be also another red flag. Okay. We already said that they struggle with money and time concepts, and we already said in the language department that they struggle with the basic comprehension more than the speaking. But the intact areas is that they have a lot of strengths as well, which is physical maturity. So they develop and then they can engage in physical activities. They're good with basic reading skills, and they're good with social skills until they start struggling. So they are social in the mean that they're actually friendly and they would like to be, involved, and they want to engage with others. They don't have the same disinhibition for as in autism, where a lot of the children with autism, they don't want to engage with others. You have to kind of put them out there so that they engage in those skills. So the next part of the presentation, then I will be talking about some of the red flags and going from infancy to adulthood. So what should we expect? All of you are working with, some of you starting with infants, toddlers, all the early intervention specialists. And then some of you are working with preschoolers, some of you working with school age, and some of you with teens and adults. So for each of your areas that you are focusing on, what should you expect? Well, first of all, in infancy, I would say that we do not have great means and methods to diagnose FASD, because the symptoms that I will talk about are very similar to symptoms to any other developmental disability. So if you ask Dr. Ergun, can you diagnose right at infancy? I would say no. We can start to track. We can start to treat the developmental delays. We can start the early intervention. That's the best that we can do. But we cannot pinpoint and say, yes, this child will develop, will have, FASD or somewhere a diagnosis under that FASD umbrella. However, this does not prevent us from having our, antennas open and just saying, these are some of the red flags. I'm going to put these down here in their chart, and I'm going to follow this child because there was also prenatal exposure. So this might turn into, maybe it's already there, but we cannot detect it because they're so young. Okay, so that's the approach that we have in infancy. So what are those? Well, they will be more emotionally withdrawal. So what that means is that, the babies they will be working with, they're not going to respond to their names as much. They're not going to smile back. So you can say, well, this is like autism. Yes, so this could be similar to that too. So less responsive to parents. They have poor sleeping. They have delayed cooing, delayed babbling. They suckle. They have a lot of difficulties with suckling, taking the nipple, taking the bottle. So all of those children that you already see that probably will have developmental delays, our kids with our babies with FASD do present similarly to those as well. So then what do? We note all of those down. We provide, just like you would do for any other developmental delay, regardless of the diagnosis, we do provide the early intervention because that would work wonders. And we don't really need to do anything that's more specific to FASD. Just providing that early, wonderful, early intervention, would be really a helpful step to get started. But then the great clinicians will be the ones who will note these red flags somewhere in the chart. So later on, when they start getting evaluated, hopefully one of you wonderful clinicians have noted it down that there are some red flags in there that should be really followed up. Okay. Then what do we see later on in toddlerhood and preschool years? Now that they're in Head Start programs and preschool programs and daycares. So now we start to see some of the things that I already talked about. So memory issues. Now we see this is the age where they learn about colors, right? Where they learn about shapes. You teach them. What do you do with your typical, preschoolers? You teach them maybe a couple months, then they learn their colors and they come home and they're so proud to show and all that. Our children who will have FASD or who already have FASD but we don't know yet, well, they'll struggle with learning the basic concepts, the colors, shapes, numbers. They become a difficulty. And you might say, wow, I've been teaching these for like 6 months now, and this child is not retaining them. They are not keeping in their memory. Every time I ask, I get a different response. And then maybe you might send for testing for IQ. It might come back normal. Remember, I said that can happen, but they do have memory issues. So I would again note those down. They could have now start to show a lot of hyperactivity, just like we talked about, aggression. One thing that we see a lot is lack of fear. Now, these would be the kids who would at school, they would just jump from places. They would maybe destroy the desks at home. I heard some that needed to kind of put locks in the home because they would just climb up the roof and try to jump off of from there. They would try to jump off from the rails at school. So a lot of behaviors where they cannot connect their behaviors and the consequences. So they have a hard time with that. Sometimes they show a lot of sensory issues, like they have excessive pain tolerance or they become really sensitive. So then you might say, oh, that's maybe autism. So we see a lot of that hypersensitivity, just like we see in autism as well. So then it would be good also to start out with some of those sensory integration, interventions there as well. And then the last piece that I wanted to say, the last bullet point, is that they really don't benefit from typical parenting practices. So what would you do with your children that you work with, and what do you suggest to their parents? Well, let's do timeout, let's do positive, reinforcement, let's do distraction, let's do ignoring, right? And a lot of the times, if the parents are consistent, some of those disruptive behaviors lessen over time for your other children, right? But then for children with FASD, their parents would come back to you and say, yeah, I tried that. Yeah, I tried that. I tried ignoring. I tried timeout. I tried this. This is not working. So tell me something else to do. So then you start kind of thinking, okay, there is more to this than a disruptive behavior. There's more to this than ADHD. Okay, so then those would be some of the times that you're going to start having your red flags up. What else happens in childhood? Well, now we start seeing more attentional issues because before they start school, I mean, they're not really supposed to attend that much. It's just 5 minutes here and there, but now they're in kindergarten and forward, then they really need to sit in their groups. They need to learn for 10 minutes, 15 minutes. Ooh, then it starts to become a problem. Because remember we said they can attend for short periods of time, but they can't do the focus attention. Now it becomes an issue because they have to, and then at school, then they cannot learn well. They also start having problems with telling time and money, which we already talked about. They have problems with adaptive functioning, day-to-day life, while other peers at the same age, they will be able to manage themselves in general, like in day-to-day life, which means starting in childhood, now they'll be able to dress, brush their teeth with, little reminders. They can maybe make sandwiches for themselves, the basic things. They can maybe clean their room and stuff. So children, or now preteens, with FASD, they really struggle with these day-to-day activities and they need a lot of monitoring and supervision. So if you are working with a family and then the parent says, I have a 9-year-old, I have to do everything for them. If I leave to their own devices, they'll do nothing. They can't do anything. And then you ask why, because they have so many problems, difficulties with completing those tasks. But again, you look at the IQ is typical. So those are the red flags that you should really have when you are listening to parents when they're coming and maybe consulting with you for interventions and for other pieces. Okay. And this is also a time when we start to see coordination issues, some fine and gross motor issues, things with like writing, spelling, holding the pencil, building blocks and things like that, where they really start struggling because some of them do have coordination related issues. The red flags in adolescence. Now, what do we get added here? Now, this is the time all of the issues continue, but now we add that naivete and gullibility, which is peers are more important. Now they are in peer groups, but now peers do understand that our children are different. And of course, not all children are fair and they can be cruel. So they start to take advantage of the teens. And then they start suggesting that our teen with FASD will engage in a dangerous action because nothing will happen as a result of that. And our teen will truly believe that nothing will happen because they have hard time tying the behavior to the adverse consequence. So a teen in a group might say that, John, we will do this prank and then we will go and, break the window of a car. And we chose you to do it because I think, you're the best. You can do that. Okay. Then the teen will, really believe in that and they will not for a second question, oh, why me? And why do I need to do it? I'll get into trouble. That's what a typically developing teen will say. And they'll try to get out of it, but still maybe be part of it. A teen with FASD might, and I'm not saying all of them will, but they might be the one to volunteer for that. And therefore, they will more likely to start to get into trouble with law or have encounters with police and, other law enforcement. Other areas that we start to have more difficulties is that it impacts their school performance, peer relationships, and their self-esteem. They start also understanding that they cannot learn the same way, they cannot remember the same way, and then they have some behavioral difficulties. So they start understanding that they may be different from other peers, and that could lead to some self-esteem issues, which could also lead to some emergence of mood problems such as anxiety or depression. So if your child is already, if your client is already diagnosed with FASD, I would say monitor for mood issues as comorbid as they move on to their teen years. So potential for secondary issues, I would say depression. So be on the lookout for depression, anxiety, disrupted school experiences. We see a lot of dropout from school. We see a lot of running away from school, trouble with the law. Also, we see now, because they're impulsive, right? We talked about that disinhibition. That could lead to drug and alcohol use, okay? And also sexual promiscuity. I cannot see that word well. Promiscuity, and this is because they have hard time differentiating what is appropriate sexually as a private behavior and what is appropriate as a public behavior. So they might think that if they go and ask for the opposite gender or same gender depending on their sexual orientation as to do something like like kissing or anything like that, they might think that it's appropriate to do because the other person, maybe a friend, said that it's okay to do. And one of the examples that I think Dr. Chasnoff in one of his books gave for an actual client that he had was a teen had a friend, a female friend, and the female friend said like, oh yeah, come along sometime and we'll study together. And one night he just went and I think just got through the window of this girl's house, and it was, I think, open, and he was able to get in there. And then she was like shocked to see him at night, and he said like, she said, what are you doing? He said, well, you told me I can come over and we can study, so here I am. And of course the parents came, and then the parents were really upset. They thought that he was doing something to her, and he, there was the police called, and of course they tried to straighten it out afterwards because he already had a diagnosis. But they thought that he was going to have some sexual advances to her being there at night. But those are some of the things that individuals and teens with FASD might find themselves in these type of situations because of their difficulties with interpreting social cues, difficulties with understanding social context. So that's why social skills training in the elementary school years would be really, really helpful to prevent some of those difficulties, and so they can also have healthy sexual and romantic relationships. Red flags in adulthood. So some of us do work with adults. So what do we see at those ages? We see that they now have difficulties with finding and keeping employment and jobs. Of course, the biggest difficulty is managing money, because managing money and day-to-day life is the biggest part of what we do in all of our jobs, right? So therefore, they would need considerable support in those domains. And if they can find jobs and have vocational training as they transition from the teen years to adulthood, knowing that they will need support in those areas, would be really helpful for the planning and the transition for the families. Hypersexuality is also a continued concern. Therefore, as I said, safety training, sexual training, starting in the elementary years, continuing in the teen years, would prevent a lot of the issues that they could encounter in adulthood, so that they can engage in healthy relationships. There is also increased risk due to the impulsivity for developing a substance use disorder. So I would say if you're working with adults, monitoring and screening for substance use would be really important. And then lack of, I wouldn't say respect, maybe that's not even the good word. I want to take that one back, but lack of understanding of the social rules. They do respect, but they have hard time understanding the rules and authority. And it could look like disrespect, but it's not. Therefore, again, working on that association between when you do this, this happens, kind of like really strengthening that relationship in the brain very early on. That's why we need the starting of the behavioral therapies really early on. The minute they get the diagnosis is really crucial, because it takes time for the brain to be retrained and then to develop those pathways so that they can engage in those behaviors with less monitoring and less supervision as they become adults. So I think that's a natural stop before I move on to my next area to see what other questions we have so I can address them.
We have a question. Please provide the source of the social skills training.
Okay, so again, I have it in one of my, for the other slides, I'll just make a note here, social skills training, okay? If maybe the audience who asked that would not mind emailing me, I would do that right after the, presentation, and I will pull that up, the specific, reference, and then I could include that. And I think there was also a request for the, I could do the friendship training, although I will have all of those in my training when I talk about the treatments. And I could also involve the reference for families moving forward. So I will have those 3 references for that audience who asked about that.
What would behavioral interventions look like for toddlers when the traditional methods aren't working?
For toddlers, okay. So I would say, first of all, for understanding that their attention span is going to be even much more limited than what we would even expect for a traditional, like a typical toddler. So if we are working with a toddler for 5 minutes, then we even have to decrease that time. So really focusing on like very small chunks, and while we're trying to maybe starting teaching some of those basic concepts like colors and things like that. So that's one. A lot of repetition, much more repetition than you would do, of course, when we are working with more typically developing toddlers. Repetition, would be really helpful. Another one is sometimes they are really bothered by sensory events around them. So I would say that providing a more sensory friendly environment where that of course that needs some assessment. Some of the children on the spectrum of FASD will have hyposensitivity. Some of them will have hypersensitivity. So if they're hypersensitive, then they will not really want a lot of stimulation. Okay, so then we have to design their learning environment where the too much chaos in a traditional typical daycare setting would be too much for them. So maybe they have to be pulled aside and they have to have more calm down time, so more frequent calm down time. And then another piece would be that they probably will have more difficulties with self-soothing. Self-soothing is already hard for even a typically developing toddler. So I would say using a lot of the strategies that we know, including like even the toddler yogas, any type of mindfulness, anything that we can involve to kind of from very early on try to teach these self-soothing skills would be really, really, really helpful. And of course, if we know by that time that the child might have FASD, working with the parents as to some of those expectations, and then how to structure the home environment, and then how to be consistent in their strategies for behavior management. So a lot of psychoeducation and parent training with the family would also be really helpful. But again, I will be talking about much more, other details and behavioral techniques that we can involve in our traditional therapies in my seminar as well.
Is it only the mother's alcohol use that contributes to FASD? If the father abused alcohol directly prior to conception, would that have any effect?
That's a great question, and I think there is a little, variable, research on that. But all in all, what it comes down to is this: if the if it is the mother, if even if the father has drunk during right before conception, if the mother doesn't drink, that only exposes the baby as a more genetic impact. Like let's say we don't know if like the mother or the father has a genetic tendency for substance use, then that's what kind of like would transmit. But as far as a direct kind of like impact, it is not as dire or it's not as influential as the mother. So it has to be a direct ingestion of alcohol from the mother, because the mother has the the direct from the umbilical cord that's going down to the brain of the baby. So it's mainly the mothers, but of course it will be a good practice too for fathers to abstain if they really know that they would like to conceive and so forth. However, that will not by itself lead to FASD.
Next question: what parenting approaches or programs work best with toddlers with FASD?
The best programs or the approaches would be first of all behavioral therapy, and in general to begin with. If our children are also in the foster care system or in the system, and they're already not with their birth parents, they also have a lot of difficulties with attachment. So any of the attachment-based approaches would also really be helpful. And I would combine those with more of our traditional behavioral, therapy techniques, where we teach both parenting skills, behavioral management, and then a lot of focusing on sensory issues. Sensory integration therapies would really definitely be helpful for teaching also self-regulation. So behavioral therapy for behavioral dysregulation, sensory integration therapy for and occupational therapy and all of those for fine motor issues as well as for sensory issues. And then attachment-based theories would be really helpful for addressing some of that trauma, and then not living with the biological parent, being taken away from the parent, and then adjusting to the new system or adjusting to the foster parent or the adoptive parent. Those would be the ones to begin with. And if there is already a language delay, I would definitely, of course, refer for speech and language therapy. So these were the ones to start out with for toddlers. And then as they move along into elementary school years, then I would add some of that, friendship training, the social skills training, safety training. And then there are more specific behavioral regulation techniques that are, involved in the programs, such as Families Moving Forward, that can also be added later on. But for the toddlers, I would list those.
And I think that's the last one.
All right. Very good question. So I feel like I'll have a lot of questions, hopefully, for those who can continue with this series, and then a lot of questions for the treatment part of it. So that gives me like a good also platform as to what are some of the things that you all would be interested in, so I can kind of prepare, and then prepare a lot more like maybe hands-on and more specific information as to how you can all help your clients who might later on develop, and who you think that have the red flags as FASD. All right, so in the last hour of our presentation, I will be talking about the implications. And so what does all this mean? So what should we expect from these individuals who already had a diagnosis, or we think that might have a diagnosis? And what does this mean for our system, for all the different areas that we're working in? Like the different, like if you're working for early intervention, if you are in the health field, you're working in the schools, you're working in the forensic field, and you might come across some of these children, because we said it's 2 to 5%. So it's very likely that you actually did, like our first audience who asked that wonderful question, you all probably have encountered, but maybe you just didn't know because they weren't diagnosed, they weren't identified. So I just wanted to know, I know I talked about different brain areas, and then I talked about different neurocognitive areas. And neurocognitive meaning like all of the things that's going on in the brain, the memory, learning, executive, all those words and fancy words that we talked about. So what do we do? What do we expect to see? What would the individual look like? Okay, so for the neurocognitive deficits, then we'll see that an individual will have difficulties with shifting from one thing to another. They'll have memory problems. They'll have difficulty learning new information or remembering what they have learned. It will take them longer time to solve a problem. They will respond quickly. That's a huge thing. They will be very disinhibited. They will have problems with inhibiting themselves, stopping themselves. They will engage in quick decisions. Poor judgment. So those are some of the neurocognitive deficits that we will see as a result of the impact of alcohol on the brain. The big main other deficits are self-regulation, so which is meaning that they could be highly responsive. Remember the sensory issues I mentioned? They could be highly responsive, just like in autism. So you touch them, they'll say it hurts so much, but we just touched them slightly. Or they could be under-responsive. They will walk around after having blood because they just fell, and they won't feel a thing. And when you ask them, they say it doesn't hurt. So they could have a lot of these sensitivities. And just like some of you have mentioned, what can we do at that toddler age when they're really getting having like a tantrum, a meltdown, because they think it's too much sensory stimulus around them, right? So then all of our sensory related therapies, sensory integration and so forth, would really be helpful to address those sensory difficulties. They could be very rigid. They could get stuck. They could they would not want to do a lot of change. So that one is pretty similar to autism. If you work with kids with autism, they don't like transition. They don't like to change things. It's a big meltdown when they even have to change from one station to another. So similar to that, our kids with FASD will experience that. They will also experience a lot of hyperactivity, impulsivity. And then the last one, very huge. Remember the impact of amygdala the impact of alcohol and amygdala, the emotional reactivity. They will react to a lot of things very easily frustrated, agitated, tendency to give up, and gets to that negative level very easily. And it will take them much longer time than any other typically developing child to get back to baseline. It could take them hours to get back to their baseline level where they're regulated. That's why a lot of the treatment programs that I will be talking about next, in my the one after the diagnosis training, is going to be on teaching them self-regulation skills. A lot of it is around that. So that's a big piece that we will be looking at. For adaptive functioning, they will quite need a lot of support and monitoring and supervision around eating, meal preparation, dressing, toileting, time management. Remember their difficulty with time? You could tell them, oh, we'll get out of the house by 5, even though they already know in their teens. Doesn't mean anything. You have to tell them 5 minutes later, 10 minutes later, we're gonna go. Now we have 5 minutes. A lot of reminders and a lot of visual maybe reminders for the younger ones in terms of time, because time might really not mean too much. And then general delays with language. We talked about difficulty with following instructions, remembering them. So let's give 1 instruction at a time, not 3 at a time. For your child with ADHD, not 5, but 3 the most. For our kiddos with FASD, let's do 1 at a time. You give it, they do it, you follow up, and then you move on to this next one, not overburdening their system that's already overburdened. Social skills, we already said that we have to start the social skills training really early on and teach them stranger danger. We have to teach them about understanding nonverbal cues. And then, of course, we have to teach them prosocial behaviors where they will not get into trouble with their peers due to their aggressive or destructive behaviors. So this last piece that I'd like to discuss in a little bit more in detail is if you are working in different systems. And I know that I haven't had a chance to kind of understand where you all are working, but I could, from the questions, I could kind of gauge as to some of those great settings that you all are working in. So I wanted to do a kind of like a sample of what that could look like in each of those settings. And then if you could encounter maybe these individuals with FASD that you might be advocating for. I mentioned this before, but 80% of children with FASD, and I might not have mentioned that, I realize, do not stay with their birth families. And the reason is that, I'm sure you can all guess, the birth families, the birth parents, also continue to have difficulties with substance use after the birth of the child. So, of course, it's not something that can stop easily. If they could stop easily, they would have stopped. So they're either getting treatment or they're not getting treatment. They are not seeking treatment. Therefore, there is continued exposure of the child to substances in the home environment, which usually leads to neglect, sometimes abuse, physical abuse, sexual abuse, but a lot of the times neglect, leaving the children with siblings and neighbors, which then leads to calling of children's services and then cases being opened and then them being taken away from their parents and being placed in the foster care system, and finally, if they get adopted in the adoption. So the incidence rate for foster care is also 70%. As we have talked about, 80% of children with FASD go undiagnosed or misdiagnosed. And then the primary and the secondary behavioral disorders. Remember, we said if it's not diagnosed, then we have all the wrong treatments. We are trying to do cognitive behavioral therapy with a child with FASD. Well, that is not going to work, even though they do not have an intellectual disability. That is not going to work. Or if we're trying to give ADHD medication, and if they have a comorbid ADHD, that is not going to work. So what's going to happen is that if they're not diagnosed, they will complicate the child's transition into and out of foster care. An example for you, I've had several clients who came for a diagnostic evaluation to me, and then how many homes did they change? On average, 5 or 6. That is significant. With each change, with each transition, they had trauma. Now, On top of the impact of alcohol on the brain, which we have talked about in detail today, think about 5 times of trauma added. So that becomes a complex trauma on top of a brain trauma that's already there. So what happens is that the brain gets more and more exposed. With each trauma, the brain gets more impacted also structurally. So what we want is that if they can be placed with a loving family who will be able to work and love this child and then provide all the needs, then the likelihood for a good prognosis is high. Research shows that if children get placed in a foster care home and finally adopted into a loving home by age 6, and if they get diagnosed, of course, by that time and start their treatments, then the prognosis is the best. It's much better. However, unfortunately, that's not the case. Because they have not been diagnosed, the children display a lot of behavioral difficulties, a lot of aggression, and then the foster care families, not knowing what they're dealing with and how they need to deal with, they give up, unfortunately. They give up on the children, and then they go back to the system. And each time the child changes an environment, that's the worst thing that you can do to a child with FASD. All they need is a stable, physically stable environment. They should not be changing. The home should be the same. They should be interacting and doing things over and over again so that the brain has a chance to rewire some of those pathways that have been lost due to the impact of alcohol. So then what can we do? We need to provide training to foster care or adoption personnel to recognize some of these characteristics. So I'm hoping that some of you are from foster care agencies or adoption agencies. Provide education also to the parents who are entering the foster care system. How many of them are clueless? All of them, because there is no structured training. With one of my doctoral students, we are developing a curriculum and a program for foster care parents entering the system, if they already know that they're going to adopt the child with FASD, as to what to expect, how to behave, how to structure their environment so that they will have a successful transition and they will have successful parenting. It's also very important for these parents to feel that they're not failing. Who as a parent likes to feel that they're failing? None of us, right? So they should not either, but we're not really doing much to help them out. So we need to develop and enforce these policies to get and also disclose some of the information on birth mother's history of drinking during pregnancy, so that if it leads in the record, then it will prompt these foster care staff to say, well, this is in the history and we see some of these red flags, let's do a referral. And that referral could lead to a diagnosis, and then the parent who is signing on with this child, if they're getting the education around it, they could say, yep, I'm ready. I know what to do. Yes, it's going to be difficult. I will do this. I have resources. I have information. So that's much different than going into this and discovering halfway through, and then they'll just throw in the towel and say, I can't do this. I didn't know this. I don't have means to deal, and I'm very overstressed, and I have a lot of, caregiver burden. So we see a lot of the caregiver burden for foster parents and for adoptive parents. So that's definitely an area we need to focus our energy on as well. Another area that we also, as committees, those who are interested in this area, who are passionate in this area, we as the FASD steering committee also work very closely with media. But media campaigns can create awareness. Remember at the beginning, I asked all of you about autism, and I'm sure all of you had some idea of the prevalence, and you all know what autism is. But it's not even in the media right now. It's the media campaigns need to create that awareness and change attitudes for individuals to engage in these healthy behaviors, including stories on the dangers of consuming alcohol while pregnant. And there should be prevention services targeted towards youth, and including those FASD information on Alcohol Awareness Week and things like that. So that's really important. What about the justice system? first of all, as we've talked about, we said that they're very open to being taken advantage of, right? And then they're very impulsive. So when we put all those together, all these behavioral impairments make them susceptible to get trouble in law. Again, 70%, that's a huge, huge number. 70% of individuals with FASD, they end up having, getting into trouble with law. And some of them, as we said, have intellectual impairments. Some of them have difficulties with their behavioral control. A lot of them have poor judgment skills. They cannot decide well on the spot. And when do individuals get, into trouble? When they have a hard time engaging in that sound judgment, right? And a lot of them, unfortunately, have a history of abuse and neglect, as we have talked about. So that even heightens that risk for attachment-related issues, and then kind of like also leading to outbursts and more behavioral issues than they already have. One area that is really needs to be also dealt with the police is that they can be really persuaded by the police to admit the crimes that they didn't commit. When one of you have mentioned about confabulation, you were right. That's one of the hardest things to deal with. The police asks a question, did you or did you not, were you or were you not there? And guess what? They may not remember where they were at that certain time of the night. They would come up with something, and whatever they came up with, instead of saying I do not remember, they will come up with something. The answer will get them into trouble. So when I do some trainings with the the justice system, like public defenders or probation officers or police and so forth, the example that I give is that teen, let's say there's a teen 14-year-old with FASD, and then we have a teen 14-year-old with conduct disorder diagnosis. Okay, the police starts to interrogate and ask the question to the 14-year-old with conduct, and then ask a question, did you steal this car? Did you do this attempt to steal this car? And let's say the teen with the conduct disorder actually did it, right? What will that teen do? How will that teen respond? Well, he or she or they will say, no, I didn't do it. They will deny it, right? They will try to get out of the situation. That's kind of like, the way to go. And our teen or 14-year-old with FASD, when they get asked a question, and if they are the one they did it, they will not necessarily deny it, that they will say, yes, they did it. So that is the way for the police also to understand that if they admit, for example, and if they did it, of course, then that's not the traditional or typical presentation. Okay, but again, the police also will not be really knowledgeable about these nuances, and then they will also force, and they will use force, and then the more force they use, and then the more words they use to understand their rights, guess what's going to happen? First, it's too much sensory force, so they'll get agitated. Two, they're already disinhibited. They will not be able to manage their hands and feet. They'll get into more trouble. Three, they have difficulties with comprehension. And guess what? What level does the police talk when they talk about their rights? Much higher level in terms of the comprehension. So they don't get it. They don't understand their rights. And they say that they do. They accept it. They don't even know where they're being taken to and so forth. And that's not because they have cognitive issues. They could be cognitively fine and intact. It's all because of some of the implications that we talked about today. Okay, they could resist the arrest. A lot of the teens or adults would know they should not. Then they'll have more adverse consequences. Just like we've seen some of that in the media as well for some of individuals who have developmental delays. So all of these kind of like put together will lead them to get into more trouble with the law. So what can we do? We can educate judges, lawyers, police, and parole officers about some of these behaviors around FASD. And we could also come out with alternative sentencing programs for persons who have committed nonviolent offenses that is more specific and catered to their needs, that because they're much more different in terms of how they could benefit from some of these programs. It won't be the same as another teen, with oppositional defiant disorder or conduct disorder. Also offering referral information for children of incarcerated women who might have been prenatally exposed to alcohol. So let's say you are working in the prison system. I've also presented to women in prison, and some of them, they already have children who have been exposed to alcohol. Well, when they're there, will they have any of those opportunities? Well, we should be providing them that referral information, and then opportunities for them to get diagnosed and start their treatment as well, right? So those are some of the things, and there are many, many others, but just starting to maybe create that, awareness in general regarding what are some of the things that we can do if we are working in these different systems. What about the healthcare system? First of all, 1 in 5 women drink alcohol while pregnant, and 15% of women do not know that drinking during pregnancy is dangerous. How many of you maybe have heard from your clients that, oh, my OBGYN said I can have a glass of white wine. That's not as dangerous as red wine. I've heard this so many times. Or they said, oh, wine is okay. It's not as bad as liquor. So we still have doctors who do maybe not promote, but they do not talk about the dangers of it within our healthcare system. So, of course, then we have the unplanned pregnancies that could pose challenges for FASD presentation, and then women make up of the 30% of the alcohol-dependent individuals, but not all of them seek treatment. Only some few of them seek treatment when they're alcohol dependent. So overall data from the CDC's surveillance system shows that only 23% of the individuals who are binge drinkers had been spoken to about their alcohol use. So what this shows is that within our healthcare system, we are not doing something right. Women are not having these conversations specifically with their providers, with their OBGYN, with their primary care physicians, even when it doesn't involve pregnancy yet. It should even start right at that level when they are at childbearing age and alcohol drinking age. They should be spoken about their alcohol use, if it's a casual drinking, social drinking, if they are getting more dependent, what are some ways that they can stop, how to get treatment, and how to get them to that level. Because it's not like, oh, you tell a client and they can stop. That's not possible. We all know that. We are all mental health providers. So there are stages to it. But most importantly, knowing that in the healthcare system is not perfect at this point, and we have a lot of flaws that actually cause a lot of issues at the front end, because less there is awareness, less intervention there is at the front end, then more difficulties that these mothers are experiencing afterwards. And then they have a child with FASD, and then they do work around their difficulties throughout their lifetime. So there is a lot to be done at that front end that we can all be also part of this advocacy process. So in our, in general, in 2005, U.S. surgeon, indicated that pregnant women or women who may get pregnant to avoid, drinking completely throughout the entire pregnancy to keep the unborn baby free from the impact of the alcohol and exposure. And there are also labels on alcoholic drinks in terms of that it could, lead to birth defects and things like that. So those are, of course, have been there, but again, just since 2005 or so, and then we are making so many great progresses through our committee work or from different advocacy avenues regarding getting the involvement of the like the Senate, and as far as for political partners too, to work on the laws where we can actually make an impact at that level as well. And this is great information that CDC found that almost 70% of high-risk women, and they were high risk to develop alcohol use as well as to engage in alcohol-exposed pregnancies. They were no longer at risk for alcohol-exposed pregnancies at a 6-month follow-up after the use of motivational interviewing. So all our methods around SBIRT, which is screening and referral for alcohol use, if there is good motivational interviewing techniques involved, and if there is good screening, just asking that question and figuring out if they are, and working with the mothers or the women around stigma, because a lot of them, just like one of the audience said, due to stigma, if my doctor knows, if my OBGYN knows that I'm drinking during pregnancy, will I lose my child? When the child is born, will they take the baby away from me? Right? These are all the concerns and the rightful, fears that these mothers have, where they would not want to be parted with their children. So how can the healthcare system help out with that? How can we as clinicians also help out with these women? Because we might not be their provider for like prenatal care to talk about those pieces, but they can be our client because their other child might be having some difficulties, and they're already bringing, and they might share the news with you that they're pregnant with another child, and we already know that they have had 1 exposed pregnancies. So that could even bring out that avenue to have those type of conversations and engage in psychoeducation with our clients, with our families who have already been exposed to it, or even if they have not been exposed to it. Those are also great conversations to have in terms of that psychoeducation and providing that, because it doesn't just have to stop at that healthcare and that relationship between the OBGYN or the primary care and the client. We all at different parts can also be involved in this process as well. So what are some more concrete things that can be done? Of course, encouraging and providing contraception for those interested to sexually active women who also drink. Screening is very, very important at that prevention level of women of childbearing age for alcohol use, to identify those at risk and provide appropriate counseling techniques to discourage drinking during pregnancy. And then also inquiring about alcohol use among all female patients. So it doesn't really start out with when you're pregnant. Really, if you are contemplating of starting a family, wanting to get pregnant, and if you're an OBGYN, or if you are working in close contact with women of childbearing age, and if you're working with them in another mental health related issue, right? Asking about alcohol use, it's very simple. Just screening for it would definitely make a difference in their trajectory. And of course, providing the in-service training on FASD. So if then the providers and the staff are all knowledgeable about what could be the outcomes, what is the impact of alcohol on the unborn baby, just like the first part of our training today, if all the providers are knowledgeable about this, then they would screen for it. But why are they not screening? Why are they not asking about alcohol use during pregnancy? How many of your own providers on OBGYNs asked you when you were pregnant if you were using or not? If you kind of can think about it, well, maybe some of you will say, no, I never got that question. Well, then you didn't use and you didn't have this. But a lot of women, if they were asked, if they had a chance to discuss, a lot of them would also have stopped if they knew all these dire consequences. So that's why it's really important to disseminate this information, and making FASD materials available in office waiting rooms and clinics. How many of you have looked at brochures or magazines while you're waiting in a doctor's office? Because we do wait a lot, right? Yes, we do. And all the times, we have all these nice brochures about different topics, about depression. We have different topics about even autism. I find things I've never seen once about the impact of alcohol exposure on the unborn baby. I haven't seen anything on FASD. Have you? Again, I can't hear your responses, but I'm sure it's probably very rare. And as the FASD steering committee, we're working on, finalizing what we call FASD red flag cards to disseminate to providers, to pediatricians, OBGYNs, and doctors' offices, different, mental health clinics and early childhood intervention clinics. These red flags that I've talked about today in a probably, of course, more succinct way, so that when people are sitting there and trying to spend their time waiting for their turn, they can actually pick it up. And if one person reads about this, then they'll be able to maybe change their trajectory and then maybe start that discussion with their own provider. So I think that's really, really important work. And I think the last piece that I have is the schools. And after that, I will take the questions. I think that will give us some good time to, address the remaining questions. Karen, I'm just kind of wanted to check with you to see if there are a lot of questions and that I could still address them within that time. I have a couple more slides left.
Well, with my view, I can't really see them all. It's kind of difficult to read these. You can only get like a little small section to see, but we do have this one, and then I'll go back and see if we have any more. It says, does any children's hospital that provides a foster care clinic, do they screen for FASD?
Okay, and then I think that probably the question is for Ohio. That's a great question for the foster care clinic. So I know that we have a foster care clinic at, here at Dayton Children's, and I, along with the steering committee, I developed a screener for FASD that we're trying to pilot and launch, and then have the foster care clinic use it to screen for FASD. So we are in Dayton and Ohio, we are working on that process currently, and that's a very active project at this point. I know that Cincinnati Children's has a foster care clinic. I know that there are, psychologists, developmental, specialists that are working there. I am not sure at this point, and I can check that to see if they are actively screening for FASD. When I did work in our international adoption clinic at University of Minnesota Medical School, we did screen everyone coming in, and we did, work on that. We even did neurocognitive screening too, not just for the symptoms, but we did a whole, screening on all of the things that I've talked about today. So that was definitely part of that adoption, clinic. But I know that it's not a standard procedure either, and that we have a lot of also flaws and limitations in our screening process for FASD as well. And then the biggest is the lack of a unified or evidence-based or just a well-accepted screener not being out there. So that's why we wanted to really focus on developing one and see if it's actually a good one to screen for FASD, because it's at the initial stages of its development as well. But I can gather a little more information. I do not have the knowledge that all of them do. I know Cleveland's Rainbow Babies, they do diagnostic work, but as far as for the adoption, clinics within the hospitals, I do not have that knowledge that they routinely do.
And the next is more of a comment. It says, I want to attend the training for foster parents when it is ready. I have been a foster parent for almost 6 years and am past due on this information.
Definitely. So this is this is kind of a little bit of a long term, but definitely what probably I would love to do is, once that's done, I would be happy through our FASD steering committee to present that information, because that's going to be something that I, along with my dissertation student, will bring about, and then we'd be happy to share it through different webinars. So So please follow the website for FASD steering committee for future, but that will not be finalized till next May because it's a dissertation project. And for those of you who have been in that training, appreciate that it's a long process. But when it's out there, we will definitely do webinars and we will advertise it. So just keep on watching for the webinars and trainings on the FASD website. And of course, we'll try to publish that as well.
Will today's attendees automatically receive links for follow-up trainings in the series, or do we need to re-register somewhere? Those trainings will be sent out prior to each training. We have one in March coming up. We have one in April, May, and June. So prior to those, we'll send it out to the listserv of people that we've been sending them out to. So no, you won't get a link to register from here. Let me see, Dr. Ergon. Let me see. Someone has another comment. She says, you have been a fantastic presenter. Thank you. I am very excited to learn more from you.
That's great. Thank you so much. Let me maybe finish my couple slides so that we reach our objectives too for finishing up. And then I think I'll still have that extra time because I can finish in 5 minutes and we'll still have that time for the last, few questions there as well. And I'll also be hanging out after the presentation is done and I can put on my video as well. I'm happy to, meet some of you or, address your further questions. Okay. And then the last piece I'd like to talk about is the implication in the schools. Nearly 74% of the adults report that they begin drinking before, the age of their, 20s. So that means everything is starting way early on during the school years. So 60% of the adolescents ages 12 to 17 who drink are binge drinkers. And remember, we talked about the the dangers of binge drinking during pregnancy. And among the 34% that are currently sexually active students nationwide, and then the 25% have used alcohol or drugs before their last sexual intercourse. So that puts them into that alcohol-exposed pregnancies. And of all of the substances of abuse, between drugs and alcohol and smoking, alcohol, remember I said that too, produces the most serious and adverse and harmful neurobehavioral effects in the fetus among all. So therefore, we have a lot of maybe messages about drugs, but I do not feel that we have that strong message about, as strong of that for alcohol. And that has the most dire impact. So I do believe that more work in the schools are needed. So what do we need to do? Include information about FASD in our health and human development classes, providing alcohol-free recreation entertainment opportunities for our youth, and support that FASD peer education programs, and then making sure to encourage student participation in FASD community coalitions to meet their required community service hours for graduation, because they have a lot of those volunteer experiences and so forth in high school. So why not some of them be in being part of committees, coalitions, just coming in a hearing and then disseminating the information back, and that would provide information to one teen that will go on to be a college student, engage in their sexual activities. And if we can prevent even one person from an alcohol exposed pregnancy, then we have success. And then some of the implications for school. Some students have really lower IQ, right? They're the ones on the lower end of the spectrum. And then we have some who are in the superior range. But then what did we talk about today? They all have lower adaptive functioning. So they all struggle day to day, regardless of their IQ. So, and we also talked about problems with processing information, right? And comprehension. So they will struggle, all of them will struggle at school, regardless. So this poses a challenge for educators who teach our students with FASD. And of course, like all of us, the teachers will have a hard time recognizing FASD. To them, it will be, oh my God, Mary is just so hyperactive. Or John cannot sit still. I cannot possibly teach him. Or Seth has these sensory issues. He probably has autism. Or Kendall is not able to learn. Probably they have, some kind of intellectual disability. So those are some of the things that the teachers can recognize, but they will not be able to recognize FASD. So we should be providing in-service training for teachers how to recognize these red flags and giving them some educational strategies, how to best address the needs, how to best structure an environment of a student with FASD so they are successful. Once that's done, they thrive and they have such fantastic experiences within the school system. And my last slide is on, and this one is a segue to get to my next, training. But if we don't do any of these things that I've been talking about within all of these systems, if we are unable to recognize the symptoms or the red flags, if we are unable to engage in screening and referral and appropriate diagnosis, what happens? What happens is individuals with FASD, they already have primary disabilities, a lot of neurocognitive and neurobehavioral impairments that I detailed today. What happens is now we add more disabilities into their plate. What are they? Depression, anxiety, disrupted school experiences, drop out of school, trouble with the law, sexual issues, drug and alcohol use. So we pile it upon them on and on and on. So they have the FASD symptoms, plus if they are not identified, there is lack of appropriate treatment, and then that leads to secondary disabilities, which means that we're failing them. So we do not want them. So there is so many things all of us in all of our different settings are able to do. And that's why today I wanted to, for those of you who were not as familiar, I wanted to introduce you what FASD is, how it happens, how can we prevent it, but if it's there, how can we recognize it? What are some of the symptoms, the brain areas impacted? What are the red flags? How does it look like in an infant versus how does it look like in an teen or adult? And then at the very different levels in the systems, what can we all do in terms of our part? At least, can you maybe take these slides and talk with some of your supervisors or some other providers and say, can we maybe, talk about some of our cases in our case consultation as to maybe identify and refer. And in my next presentation for the next month, what I will be talking about is starting from here. Now that we know what FASD is and the symptoms and red flags, how do we go about screening it? What are some screening tools? How do we refer for services? Who do we refer for services? Because it's a quite complicated process, as some of you as caregivers will appreciate that. And then how do we go about diagnosis? And a lot of you have excellent questions that will put me to work to hopefully putting together a nice presentation to talk about different diagnostic procedures that are out there. That is also a complicated process. And I'll be talking about how to diagnose, who diagnoses, what is that process like. And then after that, following that, then the next month, then is going to be about the treatments. And then for the next two after that, I'll be talking about very much detailed about schools. Okay, now you have a child diagnosed with FASD, and the child is a school age. How do we advocate? How do we talk to school? What are your rights within the school under IDEA, within an IEP or so forth? How do you advocate? How do you teach your child? How do you make sure that they're successful? And then in the series, my last, I would like to talk about, which some of you have mentioned, the stigma. What are some of the diversity variables that impact the presentation, the treatment, and advocacy for FASD? So we will be talking about stigma of the birth from the birth mothers. We will be talking about stigma of having a child with FASD, whether you're the birth parent or not, adoptive parent. What are some of the diversity factors like race, ethnicity? Can they get services? Maybe some of our minority youth have harder time accessing to some of these services compared to the majority. So what are some of those factors, and how can we all engage in diversity competent culturally competent practices to serve and to advocate for all of our children, adolescents, teens, and individuals with FASD. Well, thank you so much for listening today. I really wish that we were also face-to-face and I could see all of you and appreciate the time that you've given to listen to me. And if you have further questions, and I know I took some notes to send some references, please email me. I'd be more than happy to send you some questions, your responses. And I'll also stay along a little bit to address anyone's, further questions. And I'll take the rest of the questions as well before we are also done. So thank you very much.
Well, Dr. Ergan, you have a lot of comments thanking you for the training and that they really appreciate it. Also, they were asking about the next trainings, and I put it in the box for everybody to see the next 4 trainings.
Mm-hmm.
Someone asked me for the dates. It's March 19th from 1 to 4, and that's screening, referral, and diagnosis. For April the 23rd from 1 to 4,
mm-hmm.
advocacy and resources, and May 14th, 2021, how to navigate the school system, and June the 4th from 1 to 4. Those are the next, and that was for diversity competence. So those are the next 4 trainings. It should be in the chat box also.
Great, thank you.
I'm gonna see if I see anything else. Thank you for your time. I enjoyed learning about FASD. I need to sign out, but I wanted to thank you ahead of time.
Thank you for all, and I know everybody needs to be at certain places. I'll just hang out for extra questions, but have a great weekend, everyone, and thanks for being here today.
I'm looking. What about drinking while breastfeeding? I see this often and wonder
whether that would have an impact, because the baby is now born and that cord between that umbilical cord and that part is gone. It does not have as dire of an impact, but of course it's not preferred. Pregnant women, breastfeeding women should also refrain from drinking, totally, or if they drink, they should just pump and then drink, and then give the baby the milk that they have pumped while they weren't, the alcohol was not in their system. Okay, so it's not like they can't drink at all. A lot of women engage in that practice, but doing that and then that could still have an impact, but not as maybe that as structural as it would when they were pregnant. Though the worst is when they're pregnant. So still refrain, but knowing that again, it's not as much of a dire consequences as when they were pregnant, because then the baby's brain is not fully developed. It is forming, and it passes directly to the brain.
Is there a proper way to address this in our local school systems in regards to them receiving training, or who would be the best person to go to in regards to this?
I think if the schools would like to receive training, something like this, for example, and it could be geared towards like the one that I will do that's more specifically to schools. I think, of course, the school principal has to have the buy-in, and they would want to think that this is the important piece. So if you are working in the schools, talking with your principal, the school psychologists, school counselors, because they're in the mental health field, they would probably more in the role of maybe talking with like middle schoolers as it comes to some of those sexual issues and so forth. But I think you need to get in the buy-in from the principal to make sure that this can be one of the maybe in-service trainings to the teachers and the school staff. Usually those were the ones that we have done, but some of our committee members also can contribute to that. I know, Trace, you work a lot with teacher trainings and school trainings in different areas. What if you think about another revenue or avenue where you can get in touch with the schools, feel free to comment on that as well.
Looks like a bunch of thank yous. Let me see. And just saying how informative.
Yes, hey Karen, it's Shar. I just wanted to jump on for a second because you're getting a lot of comments in the a lot of questions in the comment box. They're wanting to know about the evals and the evaluations and the CE certifications. So someone just told me that it was kind of when I gave my housekeeping rules, it was sketchy. I guess my voice was going in and out, or the microphone was going in and out. So I wanted to reiterate, when you exit out of this particular training, there's going to be an auto population of the evaluation. If you please fill that out for us, greatly appreciate it for feedback purposes. And in regards to the certification, everyone will receive those within 2 to 3 days. I have to verify attendance time, how long you were on, who left, who came back, that kind of thing. So I'll send out the certifications within 2 to 3 business days. And then as far as Dr. Ergon's PowerPoint goes, if you could please check your registration email box sent it during the course of the training. Does anyone have any other questions? Please feel free to submit them and I will try to get back to you. Again, if it's something that you think of that you haven't thought of now, something that I did not cover, please feel free to send an email to our FASD email box and I will get back to you. Thank you.
Thank you, Shar. Yeah, everything else seems to be about the CEU process, Dr. Ergen.
Okay, so no other specific questions about the content?
Yes, that's it.
Okay.
You might want to look at the questions before you sign out, just to make sure. But it looks like
let me see if I can.
It says on a state-by-state basis, do you have any resources for adults with FASD? I have a nephew suspected and parent of a client with it. The nephew is adopted. Yeah, so they're just asking for adult resources.
Yes, and I think we have a resource list for adults?
We do.
Our resource directory?
We're working on updating it. Correct. It's on the FASD, the Ohio MOS FASD website.
Yes. I think that would be a good one to start out with.
I know treatment is coming in the future training, but could you put together a list of, let me see.
The evidence-based ones? Yeah.
Resources again. So the resources are on the Ohio MOS website. I'm going to put the address in there for resource.
And then if you could also, because I know there are still some folks hanging out, I know my slide is up there with my email, but if it needs to be in the chat too, for those more specific, ones looking for references and so forth, if they email me directly, I'll be happy to send those, references. And of course, they'll be in the reference, in the slides for that treatment, training. But I'm happy to send them now before waiting for it, so they can start researching those.
Correct.
Send me a direct email. I'm happy to do that.